Hi, my name is Peter. I'm an emergency physician from Denmark working in Stockholm. And today I want to do a lecture that I did in January of 2024 for some of our newer doctors in the emergency department called Making Good Decisions in the ED. I've done this lecture several times, but I keep updating it and trying to improve it. So if you've seen some of the earlier versions, there's not too much new for you. But I will add some new concepts here and there. And this is a lecture that I'll continue, I think, to update, because this is a lecture I've been asked to give many times, and I'm trying to make it so that it's as understandable as possible. So this is the 2024 version, at least the first one. So here we go. As always, I have a reference page where you can, if you're interested in decision making in emergency medicine, then I encourage you to start here with these links, and then you can work yourself from these links and further. If you contact me, I can gladly give you some more nuanced stuff, and also my other, like my blog posts and my videos, my podcasts usually have more nuanced stuff as well. So, but begin here and then work your way up. Okay, so before heading into the lecture, I just want to give a shout out to my colleague and friend Eric Driver and his course, the Emergency Medicine Core Competences course. It's a course that I'm biased because I've been the instructor of it for 8 years, and a lot of the things that I'm going through today is something that we teach on this course. Don't be sad if you're not totally comfortable with all of the stuff that I'm going to go through today. Most of the time people aren't, because the theory is kind of heavy, and a lot of the things that we are talking about today, sometimes you may think are intuitive, but may be a bit different than the way that you have been taught. Because this is not the traditional way of teaching emergency medicine in schools, or medicine in general in schools, at least not in Scandinavia, but we're trying to change that. Most of the time we do this course in Lund in Sweden, or we do it in Belgium or other places in the world, in Denmark as well. And it takes a week with cases and real life, like simulations from real life that we've like made simulations of, and then going back to your clinic and actually having some kind of champion in your clinic to be able to discuss cases in this kind of way, like this probabilistic way that I'm going to teach you today. That's what it takes to kind of get good at it. So don't be discouraged if you don't know the things, or you don't feel that you know everything after this lecture. You will get there if you practice, and I'll encourage you to go to the course. The EMCC course is the international course, or you can do the Swedish one called it's the SK-kurs, akutsjukvård för akutsjukvårdare, or emergency medicine for emergency physicians. Yeah. All right. And it's free. All right. Enough about that. Shortly about me, I make videos and podcasts and blogs, and I've done it for a handful of years now, maybe 5 or 6 years now. Partly as part of IDEM, Younger Danish Emergency Physicians, and also DASEM, the Danish Emergency Physician Society, just like SWESEM. I've been a member of DASEM and IDEM for a long time, and have also been one of the founders of IDEM. But now I'm mainly involved in doing videos and podcasts and doing blogs and teaching. So, and you can not that these videos are amazing or anything, but you can find the stuff that I'm talking about and in different levels of nuance on my homepage and on YouTube. It's free, and you can. Most of them are in English now. So yeah. All right. What we're going to talk about today is decision making. And before we're going into what decision making is, it's important to know a couple of basics. So first of all, non-technical skills is something that I love to talk about. It's quite hard to conceptualize sometimes because most people are not familiar with the concept. They kind of know when I tell them what it is. They kind of know, but first of all, they're not like to begin with. They're not familiar with it. So non-technical skills. In short, I usually use the analogy that if you think of all your clinical skills as bricks in a wall, like I know how to treat atrial fibrillation, I know how to treat subarachnoid hemorrhage, I know how to do a lumbar puncture. That are all medical skills or technical skills, right? Or knowledge, medical knowledge. Um, and that is not enough to actually practice medicine. We all know that if we've been in the clinic, because even though you have book knowledge and you may be really skilled in everything that you like technically do, then we also have to interact with patients. We have to interact with staff. We have to make things happen, so to speak. And how do we go from making things happen to for knowing how to do the stuff to actually making it happen? That is what Scott Weingart usually call amateurs talk strategy, and experts talk logistics. So the strategy here is knowing what to do, but the logistics is actually doing and actually getting the stuff done. And there's a gap there. The gap is filled by the like all of the glue here in the bricks, or the mortar, I think it's called. That is what keeps the bricks together. That is the non-technical skills. So so our non-technical skills is something that is additional or concomitant or symbiotic, so to speak, to our technical skills, right? The more non-technical skills you know and the better you are at it, the better you become at your clinical work, because then you can apply your knowledge and you can actually make the stuff happen that you want to happen. So that's why it's so essential to talk about these things, and I'm baffled that it's not taught more. So what are some of the subgroups of non-technical skills? Well, some of them are communication, communication with patients and with the staff and with everything else, like feedback, like communication as a leader in the trauma room or in the emergency, in high yield situations, right? It's teamwork, and as part of teamwork, there's also leadership and followership, like how to be a leader in a resus, or how to be a follower, how to be part of the team and actually doing what you need to do, but not disturbing unnecessarily. Situational awareness, being able to pick up what you actually need to pick up, like being aware of something that you wouldn't be aware of if you didn't have situational awareness, and actually applying and like finding out what count as a puzzle piece in this huge puzzle. And maybe and better analogies, maybe as a psychologist called Gary Klein talks about, if you mix five puzzles and mix them together, then you kind of start to know what it is like seeing patients, because we often talk about, well, putting the pieces together. That is not the case. That is not that if only was putting the pieces together, but we actually need to start before that. We need to start at what counts as a puzzle piece. Okay, so we need to figure out which of these five jigsaw puzzles actually is the one that the patient needs to get sampled today. So we need to pick up all the pieces and see, okay, is this a piece? No, it's not a piece. So we have to prioritize the pieces, and then when we have the pieces that we think are good, then we can begin to what you call sense making, or picking like pulling the dots together to form this kind of pattern. So it's usually we just say, oh, we're just putting the pieces together. That's a later stage. We need to know what counts as a piece before that. So that situational awareness is all about these like stages through how do we gather knowledge, how do we see what others may not see, how do we figure out how do we put this together, and how do we, when we're putting it together, how do we come up with a strategy to actually do something about what we think, and how do we feed that back? How do we know that when we feed it, when we've done something, how do we know if we've done it right? That's all about situational awareness. So in terms of ABCs, it's doing your ABCs and actually picking up the data that you need. It's figuring out a pattern. It is treating that pattern and seeing that, oh, it wasn't that pattern, it's something else. We need to treat something else. We need to gather some more data. That is all situational awareness from the beginning to the end, right? Then you have decision making, and decision making is decision making is what we're going to talk about today. But in general, decision making is kind of, all of these non-technical skills are overlapping with each other. So there's part of decision making in situational awareness. There's always part of communication in almost all of these, in teamwork, in situational awareness, and decision making. All of this, like, so they are overlapping these areas, and there's many books and many, like, there is not a perfectly described area of this. There keeps coming more areas to talk about, but these are my usually the ones that I teach, or I set up as the bigger groups. But you can do you will see other books having other groups. So it's not necessarily the terminology is perfect. It's more that we kind of know what we're talking about, and we have words to actually and the terminology to actually describe these things, because it wasn't there a lot of the 10 or 20 years ago, and I bet you haven't heard about it, and or you haven't heard a lot about a lot of these things in school. So that's the main thing here. And decision making is part of situational awareness, or at least when we've gathered the data and gathered all of the puzzle pieces, then we kind of need to know, okay, where do we go from here? And how much does each puzzle piece weigh? How can we make decisions so that we don't unnecessarily cause what we call opportunity cost? We do something that is maybe not harmful, but it just wastes time that we don't have with critically ill patients. Decision making is also about like probabilistics, like likelihood ratios, as we'll go into in a little while, and so on. So that is like, how do we make decisions, and what do we base those decisions on? Because coming to an outcome is not the most important thing. It's the way there, and how you would apply that for the next patient. Like, if you have these data points, what would you do with them? That is decision making. I don't care if you come up with, this is a pulmonary embolism. I want to know, why did you do that? Because if you have no clue and you just shot in the dark, did it CT, and you found out, then you haven't, then there might be something that you're missing, and you cannot apply that next time. You're not learning anything by doing that, and the patient is nowhere, like, is it even relevant for the case? Is it a small pulmonary embolism that you found just by accident? So it's much more about the way there, the process of diagnostics, more than the outcome, as we'll go through. Task management is another field that overlaps. Like, how do we manage our task? How do we prioritize our tasks in the emergency room or in the emergency department? Performance under pressure is usually not part of the non-technical skills. It's kind of on the periphery, but I definitely think it's really an important one. So I always bring it in, and I'll talk shortly about that in the end of the lecture. And then deliberate practice. How do we actually get better once we have done the case? How do we learn something from it? And how do we, instead of just learning, instead of just being exposed to the clinic, like, I see these 10 patients today, and then I go home, and then I see another 10 patients tomorrow, and I'll do the same thing. Instead of doing that, then we reflect on what was hard and what was good today, and what was done well and what was done less well, and pick out the things that were done less well, and then try to drill those or become better at it, or try to discuss with colleagues why, so that we don't just go through and expose ourselves, but don't reflect and don't learn anything about it, from it. I'm not saying we should do this every day. But it's something that should be a habit of ours to reflect and go back sometimes, and more often than not. And you may use it, and you may use this analogy where you go through if you have a song, and if you're playing an instrument, then you play the song, and you may be able to play the song, but you cannot play the solo, or there are specific parts of the solo that's really hard to actually play. And what you do with deliberate practice, as opposed to just playing the song 1,000 times, that is, you go to you play the hard parts. You don't play the easy part. You don't practice the easy parts, because those you can play those. You practice the hard parts, and then if you go and then you practice those, and then you become better at it usually. After a while, you've developed some kind of mind map. We'll go through into that in later in this video, but you develop some kind of mind map, and then suddenly you become better at it, right? But you wouldn't become better at the solo by just practicing the easy part of the song. So you need to. That is part of like teaching theory. Was one of the cornerstones is deliberate practice, that you need to train things that you're actually not good at, or where you have problems, and that requires you to identify the things that are harder for you than others. And that takes, like, we go back to communication again, like feedback theory. How do we accept feedback, or how do we get feedback instead of giving? Like, yeah. That's an entire different lecture. I've done that lecture, and you can look it up on my channel, about feedback theory and why it's more important to actually be able to give, to get feedback than to give it. Because if you can get feedback in a good way, then you're not, then you can extract something from every encounter. Like, even if it's just 2%, you can see the good thing over there. That even if feedback is delivered really poorly, and in a bad way, and in a bad situation, then oftentimes you can reflect afterwards and see, oh, maybe there was just 2% I could get from that. And then you can like accumulate that kind of knowledge. Okay, so that's just a quick run through what non-technical skills is. Today we'll be talking about decision making, and we'll not talk about too much about the other things today, but because they overlap, we will get into some of the weeds with the other things as well. Okay, that's one of the basic concepts. Then, before going into decision making, I think it's important to ask the group, what is the purpose of emergency medicine? Because if we need to make good decisions, then we need to know what the basis of these decisions should be. And it's important to be humble about this, I think, because we are doctors because we want to, like, the purpose of being a doctor, as is said in one of Bernard Lowndes' books, called the Lost Art of Healing. One of the purposes of being a doctor, or maybe the purpose, is that the patient is better as a product of our encounter with them. All right. So if that doesn't mean that we have to cure them. That doesn't mean that we have to like fix their problem, but it means that they have to be better. We shouldn't make them worse through iatrogenic harm, and that's really hard to do, especially in modern times. So, with all the things that I can do in the emergency department, is it a good thing for me to be there? What is the purpose of me being there? And if I and it's important for us in medicine in general to like be able to commit apoptosis, so to speak. If I'm not giving the patient value through my encounter as a specialty or as a thing in healthcare, then I should not exist for them. And I think it's really important that all of us think about that, no matter what kind of specialty we have. Because right now, medicine is outgrowing us, right? It's becoming more and more expensive, and we cannot afford it. And a lot of this low-value care. So we also have to think deep and hard about, is this something that is important for the patient, this concept? So is emergency medicine important for the patient? Well, I would argue this, but I love to have comments about whether it's not. Please post your references as well, because and your ideas, because this is worth talking about. But the way I see it, and Ruben Strayer has done a much better job at doing this than I have in the links that I have in the references. But in general, I think there are three main big purposes in emergency medicine. There's the what you can call the numbers needed to treat equals one. That when I see a patient, every time I see a patient, they should be better as a product of our interaction. And again, doesn't mean that I've fixed the problem, but it means that I've been compassionate with them, or treated their problem, and or have explained something to them so that they're not as anxious about their symptoms or something like that. So that I've moved them one step closer to being better. And that could also be just being self-reliant, self-empowering, right? Like Ivan Illich would encourage us to be. Um, so that could be it. So that's part of what we do in emergency medicine and all of medicine, right? But also in emergency medicine. Then we have this thing about the zero-sum game, because I don't only see one patient in front of me. I see several patients all the time, right? I have several things going on at once, people coming in and people going upstairs. And if I use time with one patient, depending on your emergency department setup and how many doctors you are and so on, but if I'm spending time with one patient, then I'm not spending time with all of the others. So I need to weigh my time. That doesn't mean that I shouldn't spend time on the chronic pain patient, but sometimes, because oftentimes it's well spent time with them, because we are the only point of interaction with their healthcare system that they often get. But I need to be aware if a trauma is coming in, a critically ill patient, then I need to go. So there's this, as David Fatovich, an emergency professor, has called the inverted U curve of time in emergency medicine. That in the beginning, we shouldn't spend too less or too, like, it's a Goldilocks thing, not too little, not too much, but just right. And it depends on the patient and the day and the department you work in. This is a thing that we have to. This is a thing that is part of emergency medicine. But as we'll talk about today, mainly the time critical conditions are important as well. Like, the time critical conditions of the individual is important, right? That takes priority, and that maybe take priority over all the other things, because I need to help the patient in front of me, and I need to rule out the time critical conditions. That is like the main thing. But the other things weigh in, because sometimes you have two time critical conditions at the same time, and sometimes the time critical condition is unsalvageable. Then maybe it's better to spend time on something else, right? With patients where we can make them better, so on and so forth. It's complex, but that is some of the priorities in emergency medicine. And usually, time critical condition is and finding the time critical conditions and treating them or ruling them out is the main purpose. And is it important for the entire healthcare system that we have such a thing as emergency medicine? I think it is, because the specialties, well, there's lots of arguments here, but and lots of good arguments for why. But one of them is that the specialties are becoming so specialized that they don't have overlap with their older selves, so to speak. So a patient coming into the surgical emergency part, like the emergency room, the surgical part of the emergency room, with upper GI pain, they may, as the surgeon is not educated in the same, like, or is not an expert in emergency medicine, they would not think probabilistically in the same way that we are trying to teach here. And nothing against the surgeons, but they might miss the ACS. I might miss the ACS as well. I'm not perfect, but they will probably miss it in a higher rate than I would. That is at least the argument for emergency medicine, that one of them that we can we see the sick patient. We don't see the sick surgical patient or the sick neurological patient, because we need to consider differential diagnoses from all areas of the medicine and surgical house, so to speak, with a focus on the time criticals, right? So we're kind of generalists in emergency medicine, and that's needed when the patient comes in. But in some systems, you have primary care physicians that may take a big part of this. So it's a liquid thing, and that is part of also the essentials of emergency medicine or the emergency physician. I'm kind of liquid in my core competences, or the core competences may not be liquid, but when you go to Greece or you go to Belgium or you go to the United States, emergency physicians usually do totally different stuff. Not like if you take a neurologist in these places, they would probably do kind of the same thing, maybe with some nuance differences. But in general, emergency medicine is much different in a lot of countries, depending on how the healthcare system is built up. But it seems like there has been a need for them, or for us, in most systems. And we are adaptable to what is needed in the emergency department. So in Denmark, for instance, where I'm from, there's a closed emergency department. You cannot get there unless you call 911 or 112, or you get referred there. In Sweden, that's totally different. You can go in, walk through the door, just come in. And that gives a totally different perspective, or a totally different like way of working. Now I get patients from the street, a lot of them really low risk, and there's a lot of them. There's a lot of crowding, and in Denmark it's much higher much sicker patients, because there's a filter before filtering all the less sick from. But I can work in both systems, but I have different focus. So that's also part of being an emergency physician, being able to adapt to different circumstances. Okay. So let's talk about time critical conditions and one of the last basic concepts here. So emergency medicine, when it comes to time critical conditions, is kind of a needle in a haystack thing. So most of the patients, especially as I talked about here in Sweden or in any other country where there's an open emergency department, we are kind of it's very much a needle in a haystack situation, because finding that time critical patient is hard, and it takes practice, and sometimes it's obvious, but oftentimes it's not, especially with more and more complex patients. And many of them don't look that sick. They may be triaged green or yellow, which is like it's not like it goes red, orange, yellow, green, blue, the new system. So it depends, but it takes practice to find that needle in a haystack. And as we'll talk about, it's really important to find that needle in a haystack, but without giving the patient iatrogenic harm, right? We can harm the patient by overdiagnosis, by a lot of the tests that we're doing, by waiting in the emergency room for 24 hours or longer, as it often is in Stockholm, to get seen, right? So we need to weigh our risk aversiveness, or our wish to pick up time critical conditions with the problems that comes with all the tests, and the problem with overdiagnosis and so on. So I usually talk about, we need to find the needle in the haystack, but we shouldn't burn the hay. So if we talk about the hay as being all of the other patients, we shouldn't do CT scans on everyone just to find the one little needle, because that would be expensive and not good to anyone, not the patient, not us, and so on. So that is why it's really important to balance this kind of needle in the haystack thing. So yeah, I always say finding the needle in the haystack without burning the hay in the process. Okay, and now I'll introduce you to some of these concepts, specific concepts in decision making that will make you a better doctor in the emergency department. So first of all, don't burn the hay. How do we conceptualize this? Well, this is from Gil Welch, and he is a internal medicine guy who's a brilliant guy, and he's made a book called Overdiagnosed, and he also has a homepage where you can find this graph, and in the book this graph is there as well. So if you think about illnesses, like take any illness, let's say hypertension is an easy one to go through, but in emergency medicine we might say PE, pulmonary embolism. There's a mild kind of pulmonary embolism or mild kind of hypertension, and there's a really, really, really high risk where the patient is syncopized, where there are low blood pressure, where there are desatting, and so on, and the right heart is failing. That's the hard one. And likewise on the hypertension, more chronic hypertension kind of level, there's also really, really harmful things over here. All right. In the extreme, you can get stuff like PRES or malignant hypertension and so on. But usually we'll see the patient who's asymptomatic, and that is also bad over a number of years. But how bad is it? Well, so if you think about the green one here, the green line is benefits. So if we treat benefits, if we treat a patient in different kinds of the spectrum, if we treat a low risk thing, there's not as much benefit because most low risk things go over by themselves, as we talk about time as a test or regression to the mean. And if we treat the patient over here, then they will get a massive amount of benefit, or potentially they will get a massive amount of benefit, because if we don't treat them, then they will die. And that doesn't mean that we can treat them and they won't die, but we give them a chance of not dying and not being invalid or not having huge problems with their body because of the disease. Yeah. Sorry, that was awkwardly phrased. But that's the treatment. Like, it goes up, it becomes better and better. The worse, you gain more benefit from treatment the more sick you are. That is that's something that we assume, and I think it's a fair assumption by Gilbert Welch, at least in chronic disease, but I think also in emergency diseases. Then you have harm, and harm is usually a straight line. You can, as Gilbert Welch say, it can wobble. Like, you can argue that, for instance, if we take PE, if you do thrombolytics, then they will have a, like, if you thrombolize the least sick PE, then they will not gain, like, they will have this amount of harm. But some conditions as PE, if you thrombolize a much sicker one, they will have a bit more bleeding because of the pathophysiology of the body's condition and so on. They will be more reluctant, they will be more prone to bleeding. And the same we see in stroke if we take thrombolytics as an example, but not much. It's like it's not very much. It's in most conditions. If you take Eliquis or DOACs or other kind of blood thinners, the risk is kind of the same across your disease spectrum. But it may wobble a little bit. Okay. But if we take this, then we can to get a ratio of, like, in the high risk, there's a high benefit, low harm. And then of course it depends on what kind of specific harm it is. Some harms are really not harms to some patients, and some harms are really, really a lot of harm to some patients, but not others. So this is just a really rough sketch of it, but that's to conceptualize the things, right? So in general, we want to treat these patients, and in general, if we go below this crossing point here, then there's in general more harm than benefit from the treatment. And it may be that as we said, the harm from specific harm, like, I'm anxious of this disease, I want to be 100% sure that it's not it, because my dad died from this and I have it in the family. Okay, then even though we don't think it's harmful, then we may do the test with caveats and explanation to the patient beforehand. But they may be willing to take that harm, but not others, right? On this left side of this area, on the left side of this convection point, or this crossing point, this is what we would call overdiagnosis. So you have the true disease. You have the true disease because it is disease in the microscope, but it would not have caused you harm in your lifetime. But treating you would would make you be more like put you at higher risk of harming you, right? Treating you a really low little PE that was found by accident and asymptomatic may be something that could cause you more harm than good. Right, and so it is for most conditions. That's the concept of overdiagnosis, and I made an entire video on this. You can check out my video called "When the Scan Lies," where I go through much more details about this. Or I have a specific video on overdiagnosis where I also talk about it. Okay, so there's a balance here in the emergency medicine, and I know that I can, like, one of my main tasks in emergency medicine is not to harm the patient, because I can, with a low risk group coming into the Swedish emergency departments, I can harm a lot of them by just doing tests, by just doing everything. Then oftentimes they will fall into this area. Even if I find disease, it's probably low risk disease and it's nothing that we should treat. But it's hard not to treat something when you're waiting 24 hours in the emergency department. You need to be able to communicate with the patient and expectation management and so on. Okay, that's another video on communication. That's another important non-technical skills, right? But that's the essence of it. So as Cliff Reed says, when emergency medicine doesn't exist, there's an unquantified cost, inconvenience, misery, and pain for patients. We protect patients from the healthcare system in a lot of ways. And that again, we shouldn't see ourselves as heroes. We should be humble about our job and our position in the healthcare system. But I think that is part of the conversation when we're talking about why we are important. Okay. Okay, so here, the majority of complaints that patients present to doctors, even though focused on one or another organ, are functional, generally arising from the rough and tumble of living. That's what Bernard Lown says. And Bernard Lown was a cardiologist who wrote this book called Lost Art of Healing. So we talk about this regression to the mean, and that's the left side of that graph I just showed you, the low risk disease. Like we all have some kind of rough and tumble of life. We may get a viral illness, something like that, and like some days it goes up, some days go down, some weeks go up, some weeks go down, and we usually seek medical attention at the point where it's on the up curve or at the top, and then we treat the patient, and we don't know whether the treatment was the thing that actually worked or it was just regression to the mean, right? So that's the concept of regression to the mean, and most low risk things regress to the mean. That's a really important concept to know. And the art is to know with the patient whether we are comfortable knowing that we have reached the peak and we're going down. And that's, for instance, the difference between a coughing patient with a CRP of after one day of 200 or maybe 20, like and seeing whether we reach the peak or not. How sick are they? How sick are they looking? How are the risk factors and so on and so forth? Because I mean, we treat a lot of things that are like what we call numbers needed to treat, right? How many patients would I have to treat with these specific data points, like these specific information, to miss a pneumonia that would have been important to treat? And oftentimes the numbers are like 1 in 10, even if we think it's really serious in CRP 200. Most things go into themselves, but 1 in 10 may be for most of us too much to accept, right? So, but that's kind of the thinking that we want to think about here. Okay. What about the patients that we don't treat? Well, we use the most powerful test in the entire universe, which is time. Time is the best test in emergency medicine and everywhere else. But if the patient is above a certain risk threshold, as we'll talk about, then time as a test is unacceptable. And that is the decision that we need to make. Are they good enough to be able to go home, to be able to use time as a test, see other providers and so on, or should they be admitted because not that they are definitely sick, but their risk is too high to send them home? That is the definition of what we do in what we like when we are evaluating time critical conditions. Okay, so that was the first concept of decision making in emergency medicine. It gets more specific. All right. we need to find the most likely and time critical conditions. What does that mean? Well, so we have different in the medical when we study medicine, we have different like ways of learning, and oftentimes if it's someone if an internal medicine person who's teaching us, then usually we'll get a lot of differential diagnosis, some dangerous, some not. We'll get and once we start reading the book, then we'll get even more differential diagnosis and so on. So if we take a patient with chest pain, for instance, what could that be? Well, you could make what you call a possibilistic list of differential diagnoses, right? That is the entire book, the entire up-to-date catalog of what can it be if someone has chest pain. And you may sometimes you may think of it as, oh, if I shoot an arrow through the chest, what kind of things could it be? Or it could be the skin. It could be herpes zoster, right? It could be some kind of skin condition. It could be muscle conditions. It could be bone conditions like osteomyelitis, or it could be something like osteoporosis or Tietze's syndrome or fractured ribs and so on. And it could be something in the heart, something in the organs, like the aorta. It could be something in the spinal cord. It could be like you go through the entire thing in some kind of systematic way. It could also be vasculature, musculoskeletal, like a system-wise approach. That would be a possibilistic list. I always like to add, though, that to the possibilistic list, we always think mechanistically. We should think mechanistically and the brain organ axis, right? So like biopsychosocially. Most symptoms are rough and tumble of life, meaning that most of your chest pain patient don't have ACS. Most of your patients with headache, thunderclap headache, don't have subarachnoid headache, subarachnoid bleeding. They have some kind of multifactorial problem crystallizing as a symptom, maybe somaticized, maybe emotions being somaticized, maybe something else. Doesn't matter. Just saying that it doesn't have to be somatic. That is important. So we need to keep in mind of the mind-body thing here. So that would be the possibilistic list, like every condition that you can think of, and like rare and likely and so on. But then no one does that, or at least that's only when we really don't know what to do. Then we do that. But then you can do a probabilistic list as well. Possibilistic, probabilistic. A probabilistic list is what is most likely. Oh, the patient comes in with chest pain. Well, the most likely thing with anyone with chest pain at this age would be musculoskeletal pain. That is the most likely. And then maybe 2 or 3 others. Like ACS is quite likely usually. So do an ECG and so on. But what we like to do in emergency medicine is taking the probabilistic list. Like how likely is this? And then picking out the time critical ones. So here's a possibilistic list from PubMed from chest pain in PubMed. It doesn't matter the numbers that much. Just ACS in one study in the emergency department was 30%. I don't believe that. Usually 10 or 15%, but let's just go with it for the sake of the example here. ACS 30%, GERD like reflux disease 30%, musculoskeletal 30%, pericarditis 4%, pneumonia 2%, PE, so on. That's a probabilistic list. And then you have a lot of like a long list of really rare diseases after that. And people can have several conditions. That's why it's not summed up to 100 always. So what a probabilistic list, a emergency medicine kind of list would be. That would be taking the most the most dangerous conditions here, and then sorting or filtering them, filling the pasta out so that all the non-critical conditions can just go out. That's the gravel kind of things. The pasta is what we want. We want to know which are the time critical ones. So we want to look at the probabilistic list, and we pick out the most likely and the time critical ones, right? And the most likely differs depending on at which time the diagnostic process you are in, right? So at time 0, then this would be the list, right? This would be the list, what we come to call the pretest probability. But at time 1 hour after you talk with the patient, you've got the vital signs, you've got everything. Like then there's if then the it changes, and that's what we're going to this change is so important. That's what we're going to talk about. How much does it change, and what flows on top of the time critical conditions? What do we need to rule out? What is the absolute risk, and is it below an acceptable risk or acceptable miss rate, as we talk about. So what we do, that's what we do in emergency medicine. I like to use this table here to show that you have time critical conditions, not time critical conditions. You have likely conditions and unlikely conditions. And in clinic, I usually like to just write up this for myself or when I teach, so that that you can see, like, these are the ones that we always, the likely ones from the history. These are the ones that we want to find out, right? These are the ones that we want to pick out and rule out or rule in. What's left is not necessary, not interesting to us. Doesn't mean that it is not important to the patient, but that's part of the communication with the patient when we're in the emergency department, depending on which system you're working in. Sometimes part of our role is kind of that thing, and it definitely is in Sweden in part. And we need to kind of manage symptoms because there's a long wait until you can be followed up. So we need to kind of manage symptoms as well and so on. But the main thing is here for us, right? And as we'll talk about, sometimes these, like the non-time critical conditions, like the musculoskeletal pains, the gastro reflux, the BPPV, they are important for us. First of all, to be able to treat the patient, to symptom manage the patient until they can be followed up, but also sometimes in diagnostics. If we can rule out, like if we can increase the risk of these, then the risk of this goes down, right? But we need to have a really good test. It cannot just be giving something to relieve your gastric pain. Then it must be gastritis. That doesn't work like that. That's not a good test. So we need to know which kinds of conditions that have a really good test, such as BPPV. And when you do a Dix hole pipe, for instance, that's a good test. That can only be that and nothing else, right? We'll talk about that. And then, of course, the other things are not relevant. The SEPRAs, I always say, like, well, SEPRAs, depending, like, the SEPRAs usually move up. If you get a lot of history and all of these time critical conditions are ruled out, then the SEPRAs are the ones that move in, right? Like the rare conditions. Especially if the patient looks sick. Like, I don't know what it is. Still, I've ruled out all the dangerous stuff, but it's not making sense. I need to admit this patient anyway, and yeah, so that's where the SEPRAs oftentimes come in, or in special populations. But I guarantee you, if you go to your emergency room right now, at your local hospital, there will be this week or maybe even this day, from the 200 patients that are waiting there during the day, one of them will have a SEPRA condition. That doesn't mean that your patient will have that one specific SEPRA condition, but SEPRAs in general are not rare, but having, like, your patient is probably rare. So seeing someone with specific conditions such as Boghauer syndrome, like esophageal rupture, that's rare. Like, you can go an entire year or two in a big emergency department without seeing that. But having any SEPRA, like necrotizing fasciitis or subarachnoid hemorrhage or Moyamoya's disease or something like that, in any emergency department or in your emergency department at any during the year, I guarantee you the list of SEPRA diagnoses will be long, but just not the specific SEPRA. So that's an important point. There's something called SEPRA retreat at bias. If we don't consider these ever, then we'll never pick them up. But we shouldn't think of SEPRAs when we hear hoofs, right? In Scandinavia, so it's a balance there as well. Okay. So let's talk about these time critical conditions and likely conditions. So as an emergency physician, part of my expertise is knowing for a certain presentation, like chest pain, I need to know a priori which conditions do I need to rule out, which are common enough so that I always need to consider these. It goes the same with headache and so on. And sometimes I can subgroup my symptom conditions, like or symptoms into, for instance, headache with pregnancy, or headache, thunderclap headache, or chest pain, sudden chest pain. So I have different, like, but so I can subgroup my presentations into smaller syndromes where I have a shorter list. And we do this all the time, and I don't have time to go into how to do that. But in general, the general concept is that you have a symptom presentation, just like chest pain, and then you think about all the time critical conditions, like the likely and the time critical and likely conditions. And then Ruben Stray has made this sun. So this sun should represent all the time critical conditions that we, in fairness, need to know about in emergency medicine. It's not a total, like, it's not all of them. It's really specific, depending on where you work, what kind of conditions that you see, and I, for instance, don't see that many STEMIs because they're rerouted to another hospital in the city, and so on. But it depends. I still need to know the STEMI, right? If it presents at my door. So we can take chest pain, and there's what you call the six of chest pain, right? The two heart conditions like ACS and pneumomyocarditis / tamponade. You have the two lung conditions, pneumothorax and PE, and then you have two weird ones: the aortic dissection or aortic syndrome, acute aortic syndrome (AAS), and you have your upper GI stuff, right? Which would be your Burghoff syndrome or esophageal rupture. It could be pancreatitis. It could be perforated ulcer disease. It could be cholecystitis and so on. Doesn't mean that people presenting with chest pain, like depending on where you're on the chest, it could be on the, like, you cannot switch your head off. You need to know kind of what are they presenting with. First of all, is it chest pain? Could I consider this chest pain? What about if it's the posterolateral chest? Is that chest pain, or is it back pain, or is it flank pain? And then there's a totally different differential from those things. But in general, that's kind of how we think. If this is a like classic chest pain, then we kind of can fit it in. If it's not a classical chest pain, or if it's like posterolateral on the back, just off the midline, then we have to have a broader differential diagnosis. But that's part of the emergency art of emergency medicine. But we kind of have these conditions, right? What I want to know as an emergency physician for each of these is epidemiology, like how common is it in different groups. Especially for the more common ones, I want to know quite specifically what kind of tests are best, what kind of treatments are good, and what is the prognosis. And I need to know the likelihood ratios, as we'll come into on the tests. I need to know the instrument reliability and so on. Because then I have kind of an archive in my head of all of these, like, through my emergency physician career, I will get a archive if I deliberate practice about these things. Some of them are really rare, what we call HALO, high acuity, low opportunity. They're really rare. Some of them are really common, and I'll get a lot of practice in those, and I can be able to nuance my archive. Each of these, like ACS, all of this, the information here is called an illness script. And emergency physicians walk around with an archive of illness scripts of all of these conditions, this entire sun. And when I hear your guys consult me for, like, you have a patient you want to discuss, then they present in a certain way, then I can hear from your SBAR, the way that you're going through your SBAR. I can hear whether you actually thought about these things or you haven't. The SBAR can sometimes be just delivered as an analysis, like, or as a, oh, I've picked up this information. You do the math, like, and that's not how to learn. You should always do a good S with good semantic qualifiers. You can read all about that in Bowen, this one here, and then the A and the B and the A, that kind of flows together, and then the R is really important as well. You need to, as a learner, come to the R. You need to have your own R, like your own recommendation before, like, what would you do if I wasn't there? What would you do? That is so important. So I can listen through the way that you go through your SBAR, and I can hear whether or not you actually thought about these things in the way that you prioritize certain amounts of information and leave out some informations, and the way that you prioritize to tell me something about certain negative things, negative findings. And so SBAR is really a good tool to actually kind of gauge whether or not you like the symptom that the patient is presenting with is something that you know enough about in emergency medicine. So practice your SBAR is a really important tool, and if you want to get good at this, you should read this article and a lot of the other things that I've shown you here. But that is the way for emergency physicians. These illness scripts and a lot of these things that I'm talking about is not unique to emergency medicine. It's just more prioritized in emergency medicine. So illness scripts is something that they would know about in international studies in internal medicine, in surgery, and so on. They may just not call it that, but that is what it's actually called in the studies. The thing about illness scripts is that we develop them over time. So for instance, ACS. I know how an ACS presents because I read the book. I know that they present in this way. They have chest pain in the middle of the chest. They are usually male, and then they radiate to the arm, and then they may throw up and so on. That's the book description, right? But as I become more clinically experienced, then I may have seen some of these patients that are different. I may read articles instead. I may have heard from my colleagues when we do cases that they can present in different ways and so on. So my illness script becomes more and more nuanced over time, right? And the thing about the nuance here is that it takes experience and deliberate practice to actually develop your illness scripts. So a patient that presents like this, classically presenting, both the expert, the yellow one, and the green one, the novice, would be able to pick up this patient has an ACS because of the way that they think an illness script is of ACS. But this patient over here was not picked up by the novice because it was maybe a woman, it was not chest pain, it was influenza-like symptoms and dyspnea, an older patient with diabetes. Then the atypical becomes typical. We know that the atypical is typical in ACS. That's kind of one of the heuristics, right? But that a novice learner may not know that, may have not seen the non-chest pain ACS patients, and so will miss this one. And that's just how it is. That's why we ask when we are novice. We ask experts that hopefully we can convey the information in an SBAR fashion to so that the expert know, okay, this could be it. Have we done this and this and this? And that is the scary thing as being a new guy, right? So, and you have all of these unknown unknowns, right? We don't know that we don't know. So we need to be humble. And we need to, if we think we know something, we should kind of take that to our heart. Yes, I can do this, but also balance that out with it could be something else. And somewhere in there, we need to be able to make a decision, right? And most people have just a rough and tumble of life when they present. It's not dangerous, but how do we know? And that's kind of that's the enigma. That's the money thing. That's the money shot, right? It's really the problem. And the challenge and the thrill of emergency medicine. But if we can, especially as novices, ask about the patients to an expert. And then, of course, the way that the patient presents, if this is our, even the expert, the patient presents like this, and the expert's knowledge is like this. There's overlap enough so that we want to work up the patient for ACS. But there's always a lot of stuff. Oh, that doesn't sound like ACS. Oh, it's like it could be the flu as well, right? And so on. And it could be the flu with the elderly patient, a woman who has flu-like symptoms, right? It's probably the flu, or it could be PMR, it could be something else, right? There's always what you would call an inherent irreducible uncertainty when patient presents, because they present in a specific way, we know something in a specific way, and there's never entire overlap. They never present as in the books. Oftentimes is said, right? But that is what we're talking about, right? So there will always be some kind of, oh, is this really this, or is it something else? And even with all the tests and all the things that we can do, there will always be an irreducible uncertainty. And if you want to know more about the uncertainties in medicine in general and how we can accept those or manage them instead of just testing patients until they die, then you should read Arabella Simpkins or Catherine Montgomery, How Doctors Think. And Arabella Simpkins has made articles. She's a pediatric doctor who's really good at this topic. All right. Then it's important of how we gather our data. And gathering data, and I've made this is more going into communication, but it's important how we actually gather our data. So we know that we should sit down, ask broad questions to begin with, that are not leading, and then listen actively without interrupting the patient. So it could be, what we need to figure out is, why are they here today? Not just the chief complaint, not just what it says on the paper, because oftentimes on the paper it's not the same. Like someone has put the patient into a box, but the box is not fitting for the patient, but it's the only thing that they have because they need to be fitted into the box to be in the emergency department, right? That's kind of the way the system works, and that's good and bad. It's good if you have definitely chest pain. It's bad if you don't have definitely chest pain. Oh, it was more the posterolateral chest pain, that's kind of more the back pain, and then it's missed. So we need to know why they're here, and even beyond the chief complaint as well. Like, so why do they present with this symptom right now? Why didn't they do it yesterday? That's often one of my follow-up questions. Like, why today? Not in a judgmental way. Like, why didn't you come in today? Why did you come in today? Why didn't you come in yesterday? It's more like, what made you come in today and not yesterday? Like, and it's a really powerful question usually, because then you can kind of gauge, okay, is it something that is abruptly like progressing, or is it just what you might call the end of the rope kind of argument? Like, I can't stand it anymore at home. It's not worse, but it's not getting better, and it's kind of stable, and so on. So that's really important. Or I just asked my primary care physician and they didn't have time, so I came in. That's also like, so you can kind of gauge the pretest probability here. Then we can talk a long time about validation and how to expectate. Like, I'll just talk really quickly about these things because it's important about the quality data gathering. Because once the patient has told their story, then the first thing you do is validate their symptoms. Validate their symptoms, because you would do that if a friend had a problem. Like, and validation would just be, oh, that sounds awful. It's really good that you came in. I often validate them by and like kind of diffuse them by saying also sorry for the wait, because that's really important. They've waited a long time, and they may have they've suffered an amount that we are not we don't know, because we're not the patient in the emergency department. We don't know how long, like, or what kind of way they took to get to the emergency department. Like, they may have been at several doctors before, and not just a day, but for several weeks, and they had to like leave the cat, and say, sorry for the wait. I know it's horrible to be here and not knowing about your condition. And it's not the most pleasant place to wait. So sorry for the wait. That's a good way to start. And it doesn't mean that you're the fault, but it's important to kind of validate them in their suffering. It's a good way to start. And then there's a lot of non verbals that you can talk about, like sitting at the bedside and touching them if it's appropriate, and so on. And I won't go into that here. I've made videos on that for instance, on my headache video. I've talked about at length about these things. It's important to manage the expectations, because the patient's expectation is, I want to know what this is, and maybe I don't want, and maybe I want to know that it's not dangerous, but we just want to know it's not dangerous, and then you can go somewhere else. Kind of, that's not, as we talked about in the beginning, that's not entirely true, but it's in a nutshell kind of what we want to do. So we want to validate their symptoms. That validation is part of the numbers needed to treat equals 1 as well. And expectations management is also part of that. Like, okay, so all through the entire visit with your patient, manage their expectations about, like, okay, so I think this is it. We just need this test, and then this will take maybe 3 or 4 hours. And if this test is negative, then we can go. Then you can go home. That's what we call flying ahead of the plane. And it's really good when you're delivering the S bar to the next, or when you're delivering this patient to the next doctor when you're going home, that you have a plan. If this happens, then that, and if this happens, then that. And the patient that they know it, then it's really easy to get a handover if that's how you work this out, how you work. So let's do that. And I know it's not always possible, but it's really important to do that to the extent that it's possible. And then after the patient part, after they've told you the story and you shut up about what you think, then and you only listened to and like kind of figuring out what are the puzzle pieces. Then you fill in the blanks. Then you can kind of, okay, now I can come with my, now I have kind of a picture of why you're here. I kind of know what the conditions are that I should be worried about. Now I need to like kind of know what the conditions could be, and then I go through a bit. It could still be a bit broad, but not too broad questions to pick out. Okay, did it come on suddenly or not? And if especially they come on suddenly, if the patient doesn't say that it came on suddenly, then usually it hasn't come on suddenly. But if I have to tease it out, then I'll ask, oh, what kind of situation were you in when you got the symptoms? What were you doing? Not just not just asking the really really narrow question of did it come on suddenly or not, because that's a high risk they will say yes or no, and that's a really important question in most presentations. Like if they came on sudden, like chest pain, boom, that's if it's intense, then it's an aortic dissection until proven otherwise. If it's headache, then it's a subarachnoid until proven otherwise. If it's an abdominal pain, then it's a perforation or something like that until proven otherwise. So the way that's the thing about the quality of data gathering. You can get information by just asking questions really narrowly. The patient could even go to ChatGPT and ask and fill in the blank, fill in their symptoms or some kind of questionnaire and fill in the questions. But that's not medicine. That's not the way that. Then the risk is that they will just they will be this entire thing that we do in the beginning, which Catherine Montgomery would call phronesis, where we kind of iteratively get something from the patient Catherine Montgomery calls it abduction as well instead of induction or deduction. It's called abduction. What we do, you can read the book How Doctors Think to go into details, but in general, like we get information, and with that information, we kind of go back to our archive or illness scripts. And then we kind of prone the patient again to see what is that, or is that, is it up or down? Is it more or left or right? And that is, and the way that we gather that data is so important, because if I ask too narrow a question too early, then I'll ruin it. Then I'll be able to lead the patient, or what they in law studies call lead the victim. I'm not allowed to. I can easily, any headache patient almost. I can if I ask the questions in the wrong way or too narrow too early, then I'll be able to just make them answer in a way so that they answer yes to the two important questions. Did it came on suddenly? Yes. Was it intense? Especially if you've been waiting in the emergency department for a long time, then it's intense. Oftentimes, like, why are you here? Well, it's a bad headache. That's why I'm in the emergency department, right? So you can easily lead the patient down that kind of path. If you that's my point about data gathering, and how both data gathering is really good therapeutically in validation and expectation management and so on. That's therapeutically, that's part of the numbers needed to treat equals 1 part of emergency medicine. Is really, really important. It's much easier to send someone home that you've been compassionate with. But The other part of the story is that you get better diagnostics if you gather data in a good way. Now, sometimes the patient is so sick that you just have to get really specific questions early on. And usually these patients have high signal, right? They're critically ill. We can see what the problem is oftentimes there. We don't have time for the big story, but most patients, 90% of the patients that we see, this is where we want the broad questions to begin with. Okay, exactly. So we gather data with active listening. We find out what the problem is and find out what kind of counts as a puzzle piece in all of these 6 puzzles that have been scrambled together now, coming in as a patient, in the form of a patient. And then we pick out the pieces from our history. We use what we call system 1 to putting the pieces together as a kind of pattern. And if it's not an emergency, then we treat it. If it's an emergency, as we'll see later, we'll treat it symptomatically. If it's not, then we'll do a cognitive forcing strategy, like kind of, okay, time out, fill in the blanks. What from these conditions that they were talking about in our head, which time critical conditions do we need to rule out? And sometimes we have to step aside, and I have to think about this. Oftentimes I can do it with the patient, and I have to kind of rule out either with questions or with tests, or with blood samples or so on. Exactly. So if it's not emergent, then we'll usually go to system 2 or have some kind of pattern from system 1 and then go to system 2 afterwards. You'll see later. And then, yeah, this notion, I always want to get this in as well. Like quality of data gathering. If someone says something spontaneously, it's much more valuable than not. If I'm teasing it out, then it's usually not as important. It's sometimes it is. Sometimes it is. If you have the stoic patient that don't want to talk, then sometimes you have to tease things out in a clever way. But if they say if the patient has not read Google or anything like that, and then they come in and they say, "Oh, it came on suddenly," and then I'm really worried, rather than if someone has to tease it out from them, right? Unless it's a stoic patient. Okay. I'll these time critical conditions that we just talked about, like this graph or this 2x2 table where we can list all of our differential diagnoses. This can also be graphically listed, and this is important, and I'll show you in a little while why. But in general, we always all patients before talking with them, they will always have the not likely ones. They're always low risk or low likelihood. The time critical ones that are likely are often rare, but likely enough so that they are a bit more likely here. And then the not time critical conditions, the not time critical but likely, are always like that's 90% of almost all the time, right? And the sum of all of these differentials are 100%. So this plus this plus this plus this is 100% if the patient presents with one thing, with one reason for their symptom. And we'll come back with the caveats and so on. But we can use this. So we can use this in different ways, because if one differential diagnosis goes up, then the others must go down because it's 100%. Okay, now we're moving into the more like nitty-gritty Bayes theorem. These were the broader strokes. This is the nitty-gritty, and this is the Bayes theorem then. Getting into how much does each test weigh, right? So the core principle of Bayes is like this. So you see this test. This test is called an ECG, as you know, but it could be a question, like does it come on suddenly or not? It could be a blood sample. It could be a CT scan. It could be anything, a test, right? And you throw this ECG is thrown in your lab by the nurse, and they ask, okay, is this what should we do with this patient? You don't know any information about them. You may say, okay, there might be a little bit of ST elevation here, and then maybe also here. So in the inferior leads maybe, and there's even a reciprocal something that doesn't look that good. But then you and then you're like, okay, but you cannot really do anything with a test. Just you need to know history. You need to know the pretest probability, because if I show you an ECG that is totally normal, that is really like it's exactly like this, and it was taken a year ago, then it's probably not a problem, right? So that is the like the basics of Bayesian theory or probabilistic thinking, that a test a test cannot, like all patients have, they don't have diseases, they have probabilities of diseases, like 90% probability or 80% probability. They don't have the disease 100%. It can never be 0% of risk, and it can never be 100% risk. It's always on the spectrum of 0 to 100. And you can never know, you can never interpret a test without pretest probability. You can never get an ECG and not know anything about the patient. You cannot interpret that, and I'll show you why. The Bayesian theory, just to make it formal, is usually called pretest probability. That's like the risk of something before we test. And then the weight of that test, like times the weight of that test. Sometimes the test is really good. There's a high weight. The way we measure the weight is in likelihood ratios. I'll show you. And then also how hard is the test to actually, like the inter-rater reliability. How hard is it to replicate or do? And you can also talk about the intra-rater reliability. How, if I do it 10 times, how hard is it for me to actually replicate this? And then we get some kind of post-test probability. How what is the likelihood if it was 5% before, and then this test is really good, so it's maybe plus 10%. Then the post-test probability is 15%. Now the patient has a higher risk because of that is the essence of Bayesian theory, and that will show you why this is important in emergency medicine. Because this is Simon Carley, a professor of emergency medicine and creator of St. Emlyn's block, which is amazing, and you should definitely check that out. I've linked it in the references, and also his SMAC talks are brilliant. But he says we're not diagnosticians. We don't do diagnoses. Like a diagnosis is a absolute, right? You have appendicitis. You have a brain tumor. That's a definite. We are probabilisticians in emergency medicine, especially. We make guesses, estimated guesses. We are meteorologists, as he also often talks about. We know that the weather tomorrow is going to be rainy. We don't know with certainty, but we give it a 90% chance, right? Or risk, depending on who you are. And the same thing is, so I'm not sure. We have here in the early stages of this symptom that you're presenting with, we're not sure. More data will come when time as a test is allowed to go on. Then we will know more. But right now we don't know, and you are too critically ill to allow time as a test just to move on, and we kind of find out that you're dead tomorrow. We will have to treat because of the risk, but it's a risk estimate. So we estimate a risk of, you have a 80% risk of this, or a 70% risk of this. And I'll show you now how to kind of gauge this, or a theory behind how to gauge these things. So Bayesian theory, some of the core principles that we talk about here. Patients do not have diseases, only a probability of disease. Diagnostic tests such as vital signs questions, exam findings, blood samples, scans are merely adjusting probabilities up and down, right, from the get-go, and up or down depending on if they're negative or positive. And how much they're going up and down depends on how good they are. A diagnostic test must never be taken out of context. That's what I talked about just before. Before ordering a test, always consider if it will change the management. Like if I'm here in the risk, then if the test is positive, it doesn't really do anything, and if it's negative, it doesn't really do anything, then I don't have to do the test, or at least I don't have to do it in the emergency department. Maybe it has to be done later on, but not right now, right? And we have to do what you call fly ahead of the plane. So when we're ordering a test, then think about what to do with the test, if it's negative or if it's positive, and manage the expectations for the patient. Like, what are you going to do if this is positive or negative? Like then you tell the patient, okay, and then you'll have, then if it's not a complicated thing, then you can say, okay, then you can go home after this 3-hour wait if this is negative. And then of course in brackets there might always come something up, and you may say that to the patient or not, but at least then they know, okay, I'm here until the 3 hours, and then the CT scan will be negative, and then my PE is ruled out, and I can go home. Good, because you already figured out that it's not ACS, it's not PE, it's not aortic dissection, and so on. You already calculated that. The next test doesn't give you any additional information on those things, right? So that's how we think. And if well, oftentimes it's like, oh, the patient has to be admitted no matter what the test. Well, then admit them now. Okay. Sometimes some services want to be specifically sure that it's a surgical condition, it's not a medical condition, and then maybe sometimes you have to wait in the emergency department until you can clear that out. But optimally, there should be some kind of department in your hospital where you can be undifferentiated to begin with. In our department, it's AVA or MAVA or EMA. That's kind of like the diagnostic process from the emergency department doesn't usually end in the emergency department. We don't have to be sure before sending the patient home or up, right? We have to be sure that they don't have the time critical conditions that we have to take care of right now. But if I know that they have something that they have to be admitted for, and I'm ordering the test that needs to be ordered before sending them up and treating them, then I can send them up if like the outcome of the test doesn't change the fact that I need to admit them, right? So, okay, model 1.0. I'll go through a few models that becomes more and more nuanced with this Bayesian theory, but it's really important, so that's why I'm doing it in this way. But you'll see here. So, model 1.0. That's kind of what I just explained. So if you have a specific conditions like ACS, there's a zero chance and there's a 100% chance. Then you have what you call a pretest probability at time 0. Okay, so when the patient walks in, we don't know anything about this patient. We just know that they're a patient. It could be a child, could be an older person. They have chest pain. That's what we know. Then, before I know anything else from the studies, and these studies are done in in big populations in emergency departments, but you're usually retrospective, right? So someone has considered this a chest pain. That doesn't mean that this necessarily the posterior lateral chest pain that we kind of don't consider a classical. It may be something else. So we need to think still, but we'll say just the pretest probability from this study makes it say that ACS is, before coming in, the ACS risk is 10%. From some studies in the emergency department in Sweden. Okay. Then we do some tests. And the tests, like the way how good a test is in studies, are done or we measure it in sensitivity and specificity. But sensitivity and specificity is kind of hard to use clinically. You may use the spin and snout mnemonic, and that may help you, but when it comes down to it, likelihood ratios are much easier, and I'll show you why. So a likelihood ratio, you just need to know kind of what it is. So you can have a test such as a ECG, or maybe an easier example would be a D-dimer. Let's say a D-dimer for PE. The test, if it's positive and has a likelihood ratio of 1, like like a D-dimer, you can go to the study of a D-dimer and you can see what kind of likelihood ratios it has, or sensitivity and specificity it has, and you can calculate from the sensitivity and specificity directly how much the likelihood ratio is. If the likelihood ratio is positive, like plus, if the test is positive, then it'll move the needle upwards, like the risk of the risk of PE will increase, right? So if it has a likelihood ratio, if you have a positive D-dimer and the studies on it show actually that it is only likelihood ratio of +1 or 1, then it doesn't do anything. Even if it's positive, it doesn't do anything. It doesn't do anything to our risk. And the same goes, like if it's +2, then it's much bigger, it's a little bit bigger. +5, it's bigger, and +10 is really big. And there's this called the tennis rule. because it's like 15%, 30%, 40 to 50% increase in risk. It's not totally true, and I'll show you why. But it's kind of it's the tennis rule is kind of, it's validated, and it's kind of, or not validated. It's a mnemonic to introduce you to the concept. So the D dimer is a really good negative test. So the negative likelihood ratios here are really good at it. It's maybe a negative likelihood ratio of this 0.1. But it's a really bad test when it's positive, right? Because it doesn't really do anything. Likelihood ratios are maybe, I think it's between 1 and 2 if it's positive. And then all tests have some kind of spectrum, right? What if it's 30, like it's very, very positive, and it's just a little bit positive? And probably there is for D-dimer and for a lot of other tests, there's definitely a spectrum, but the studies are not done on spectrums usually. It's harder to do spectrum studies. So we are left with this, and we need to like gauge our, that's why we don't calculate on these things. We just kind of know the basics, and we kind of know how to, like, is it a good test? Yes, no, and how much does it actually increase or decrease? So we talk about tests like such as a D-dimer. That is what we call a one-sided test. So, and we often fall in the water, or we kind of do the wrong thing about a lot of the tests because we think they are two-sided and they're actually one-sided. So for D-dimer, it's the perfect example. It's really good if it's negative, but if it's positive, it doesn't do anything, or almost never. Like, I may consider it if it's 30 or 20, but if it's only marginally positive, and that's what we've seen with a lot of the studies, like the year score where we can, or an age-adjusted D-dimer. I mean, it's becoming like it doesn't matter that much, but we usually use it, like, or used to at least do D-dimers, and then if it's positive, then we have to rule out pulmonary embolism. Well, if you've thought about pulmonary embolism before, then yes, but if you didn't think about it and it was not part of your differential, then you shouldn't. And like, if you have a different, and or if you find a different cause for the pain or something like that, then you don't have to, because like it doesn't change the probability at all. But the reason why you took it, that's the reason why, right? And if you haven't found another cause, then you should probably work up the PE if it's relevant. But you shouldn't just automatically do it because it's not a good test. If it's negative, though, it's good as long as you live up to the criteria, right? Within 7 days. Some studies say 14, but I would say conservative 7. And you can use it, and not on if you're on DOAC and so on. So all tests have some kind of indications, some kind of things that you have to live up to actually be able to use them, right? And with D-dimer, it's within 7 days, and you're not on anticoagulations and so on. Okay, but that's a one-sided test. Another one-sided test would be the Canadian C-spine rule. If it's negative, then it's a really good test. If it's positive, it doesn't do anything. And then you have the two-sided test. Two-sided tests are usually more expensive, more risky for the patient, such as radiology, right? A CT scan. Well, if it's positive, then it's really good. If it's negative, then it's really good. I should have made the error even longer here. But that's kind of, yeah. But these are usually expensive in some way, and many of our tests are not two-sided; they're one-sided. Okay. Now we're going to talk about the thresholds. So we have different thresholds on our 0 to 100 thing here. So we have, this is called Kashira's because he's called Kashira, the guy who's, I think he was a really prominent internal medicine guy in the 80s. I think he was leader of NIME, like the journal, and something like that. He's really prominent internal medicine guy who made this Kashira's model of thresholds. Because you have a what you call a test threshold, and you have a treatment threshold. Below the test threshold here, given that you've worked up the patient, like you need to have some kind of data acquisition, and like the patient comes in with chest pain, you've asked a good story, you've taken vitals, you've done relevant work, right? Then if you end up down here, then you can rule out the condition without further testing. That's the test threshold. Further testing would be detrimental to the patient. That's what we call the acceptable miss rate as well, because like for PEs, for pulmonary embolisms, the test threshold is usually around 2%. That's actually that's been calculated by a guy called Klein, who's like the expert in PEs, and Jeffrey Klein, I think it's called, and he's worked out that like below 2% risk post test probability after the test. Well, if you get below that risk, then the risk will increase for the patient of other bad stuff if we keep testing them, right? But if you like 2% post test probability, that means that 1 in 50 patients we will miss 1 in 50, or 2 in 100, 2%, right? If we, and that's like if you ever ask the questions, how many ACSs or how many Ps will you miss? Well, I will miss none. That's not possible. Like you cannot miss no. Like the risk can never be zero. It will be maybe 1 in 1,000, 1 in 10,000, but it will. But the problem is, if you want to go from 1 in 50 to 1 in 1,000, 1 in 10,000, then you will increase the risk for the patient for other conditions, overdiagnosis, iatrogenic harm because they find something in the scan that is problematic and you have to work it up, but it's overdiagnosis because yes, it is the disease, but they didn't have to find it. It's not, doesn't matter, and now you're only like making a person a patient and so on. So that's the test threshold. The treatment threshold is above which it's like more like it's more beneficial to the patient to just treat instead of keep on going testing. These thresholds are different for different conditions in different patients. That makes it even more complex. So the thresholds go up or down depending on how bad the disease is, how good or bad the test is, and how good or bad the treatment is. So an example could be if you have a really, really bad disease like subarachnoid hemorrhage, right? We have a really good test for it, and we have a really good treatment for it. Then testing for it becomes really, really like we need like the acceptable miss rate is really low because testing for it is really important. We have if we find it, we can treat it, and we can find it really easily with a CT scan within 6 hours, right? So our threshold to actually test for it if someone comes in with a thunderclap headache is really, really low, right? And if the patient comes in and a week after that, then it becomes a little bit higher. We don't want to test because then our test becomes a lumbar puncture, among other, and then our threshold becomes a little bit different. We may still want to do it, but we want to take like good quality history to be able to see did they actually have thunderclap headache or not. Because then they're way up here if they had. But if it's more like, oh, I'm not sure if they had thunderclap headache, they have ADHD and they have different. Not saying that ADHD, but usually it's kind of it may sometimes be, in my experience, people with a different sensation of their body, more prone to somatization. Such as a condition as ADHD, that they might be more prone to somatization sometimes. Even though all of us are, and they may feel a body in a different way. That means that sometimes they will feel they might not exaggerate, but they may the way they describe their body is sometimes more extreme than actually is. And then sometimes, like if you ask them really narrow questions and they come in within 6 hours, okay, then I'll just do the CT scan and be done with it. But if they come in much later, and it's lumbar puncture time, then I'll use the time more wisely and actually gather the quality information, see did they need it or not. So that's just the nuances of thresholds, all right? Then you have, and the same goes with treatment. If you have a really good treatment, then it goes down. And if it's, but if the opposite is if you have a really like benign disease where there's a really bad test and there's a really bad treatment, then you like then it doesn't matter, right? If you want to know more about how to like all of the like um, how good a test is and so on, then you can check out the likelihood ratios and numbers needed to treat in these homepages. The numbers needed to treat, especially carbon source evidence-based emergency medicine. There's like all symptoms, known symptoms with likelihood ratios. McGee is also like all what do you call like auscultation of the chest or examination. All examinations are there as well. And Stern is a really good book, like just a good case book with likelihood ratios and so on. So all of these are really good resources. You can check them out. All right. Then on to the nuances about this. Moving on slowly to the model 2.0, because if you have, we have the same base model here, but as I told you, the tennis rule is like if you add 15%, then it becomes 40%. Then they're like likelihood ratios are not like that, because if you have if you have something down here, if you have someone with a really low pretest probability and you have a really good test, such as, so let's say you have a patient who's screened for cancer and you have a really good test like the triple test or MRI or something like that, has a likelihood ratio of 100 plus 100, right? That but if your baseline risk is 0.01, then you won't go up 50% or 100%. You will go up logarithmically, like a small amount. And you may conceptualize this thing like in the extremes. This tennis rule doesn't really work. So that's why I'll show you the model 2.0 in a little while. But it's kind of, I often think about it like this. So you kind of know the Mercator projection of the world. This is usually the map that we're used to, but in recent years it's become more and more popularized that like the things at the top are much, on the bottom are much bigger than they actually are, and the things in the middle are much, vice versa. These things are much smaller than they actually are. Not Antarctica, this is really big, even though, but not this big. It's like it's blown out of proportion because of the way that the map is done. And in the middle, like Africa is huge, but it's not shown in like it seems as big as, I don't know, South America, but it's much bigger, right? So or as big as Russia or something like that. It's like, yeah. So the proportions are different here. So if we move Greenland to the middle here, then it becomes much different in the middle here as well, right? So a likelihood ratio of 100 plus 100 is really like, here is really like, that's the true size of it. But in the extremes, like with screening for cancer, for instance, in this extreme, it becomes distorted, right? So and yeah, Greenland here in the bottom as well, it becomes much bigger then as well. So Justin Morgenstern, who I borrowed this graph from, or this concept from here, or this way of explaining it, he usually said, like, if you have a test, if you have a good test, you can move up one or down one. If you move it into like 5 things here, like 5 your test threshold, your treatment threshold, and then this middle area you'll deal into 2, part into 2s, right? So you have 5 areas. A really good test can only move you from one area to another, and a really great test can only move you 2, right? So if you have a patient who has a high risk here, but you do a good test, you will not be out of the woods yet. And even if you do a great test, you will not be out of the woods. So the main concept here is low pretest probability with a really good test will only move you up here. So cancer screening, even if you're positive cancer screening, you will have a 1 in 10 chance of having that cancer. 1 in 100 depends on this screening test and your pretest probability. But in general, asymptomatic individuals will have a low risk even with a positive test. Same thing goes up here. If you have a patient with a high pretest probability, For instance, if you have a aortic dissection kind of differential, and like the patient comes in with a sudden chest pain in the middle of the chest, and it radiates to the back, and they've been smoking all their life, and they also have marfangs, and they have a high blood pressure now, and so on. They have a really high probability, like maybe here. If you do a D-dimer that is negative, then that's a good test, maybe even a great test, depends. But if combined with a score, then maybe even a great test. But it only moves you down here. They still have a maybe 20% risk after the workup, and that's even though all the tests are negative, they're not good enough tests. You need more tests. You need the definite test, which is the CT scan, right? So that's the concept that I want to convey. So this brings us on to the Fagin's normogram, which is a more nuanced way of seeing the probabilistics. Okay, so we have our test. We think of them as weights. This is a tennis rule, as we just talked about, and likelihood ratio 2, 5, 10, and so on. D-dimer and aortic dissection, without the score, without the AAS risk score, but just the isolated D-dimer has a positive likelihood ratio of 2 and a negative likelihood ratio of 0.05. Let's say if we have a patient that is like, I'm just screening everyone in the emergency department with D-dimers. This patient, I may have on my differential a little bit of aortic dissection because they have different blood pressures in their arms, but nothing else, no chest pain. Then if I do the test, well, they had lower probability. Now they have even lower, but not like it doesn't change much because it's in the extremes. Then maybe another patient where we have the same test again, D-dimer, and now it's like we have maybe a bit of chest pain. Atypical chest pain doesn't sound like aortic dissection. That's kind of maybe rules it out. 30% pre-test probability, then your post-test probability will be 1%, and so on, right? And after a while, you'll have like depending on how high your pre-test probability is, the test doesn't change. The test characteristics are the same, and that's also like maybe a truth with modified, that could be modified in really high risk patients. Maybe it's more obvious that maybe there's more leakage, and therefore the D-dimer is more sensitive. And like we don't always know these things, but in general we assume that the test is kind of the same. It's probably a good assumption. So here we can see that the test doesn't matter. The ECG that we just showed doesn't matter. What matters is the pre-test probability here, because that's depending on the pre-test probability, the same test will give us different post-test probabilities. So the patient with the ECG that we just saw, well, if the patient had crushing chest pains and so on, and had a high risk of ACS maybe, then if the ECG was quote unquote negative, then they'll only have a 5% post-test probability. We still need to do troponins, but if it was a asymptomatic individual, then we don't need to do anything. All right. We can also plot in these what we call the treatment thresholds here, right? On this Fagin's normogram. So this is a more exact way of doing it, but you can do it like we don't have to. This is not math. We don't carry around calculators. We shouldn't. We could do it, but there's too many factors of uncertainty here. Like, how do I assess the pre-test probability? I don't really know most of the time. How do I assess the value of the likelihood ratio and the integrated reliability? I don't really know, but the concepts are really important. The concepts that we've been through are really, really important, and this is the way that we are going to talk about it. Another way of seeing it is like, okay, we have a patient with DVT, has a certain pre-test probability, maybe Wells score 4, and there's a clinical like swollen leg. Then you do the D-dimer. That's a good test, but it doesn't really get us all the way down to 0 or down below our test threshold. So we have to do the next test, and then our post-test probability here becomes our pre-test probability for the next tests for the ultrasound. And then if the ultrasound is negative, then it's good. That's also a way of seeing this. Okay, moving on to model 3.0. which is the landscape of illness. So we don't only think about one diagnosis at a time. We think about several diagnoses at a time and how they kind of interact in between, like the likelihoods of the diagnosis interact. I usually call that landscape of illness. And we go back to this graph I showed you as a teaser before. So if we just take a case example, so let's say we have someone with chest pain, a 50-year-old patient with chest pain. Then we have the time critical conditions that we want to rule out. We could do all the 6, but we just done 3 here: ACS, dissection, and PE, depending on the history, right? And then we have your not time critical conditions, musculoskeletal, that's always most likely. And then you have all the other differential diagnoses that I haven't even thought about, like psychosomatic and so on. That's always the most likely. And some separas may be luring here, but most of it is just unlikely stuff, because that's the definition of a separa. It's unlikely. Okay. Then I do a test. I ask if the pain is worse. And then what happens? I've asked, the patient says that the pain is worse with inspiration. Then our ACS risk goes down, our dissection risk goes down, because our illness scripts of ACS doesn't, like, I'm not saying that it couldn't be, but it's less likely, right? A little bit adjusted down. PE, it fits more well with PE, and it fits more well with musculoskeletals. And once some of them go up, the others must come down, right? Now it becomes more likely that we kind of know what it is, and it's not the other things that are more likely than now. This assumes that the sum of all of these things are 100%, right? The sum of all differential diagnoses are 100%. And we can assume that in most patients, because like they don't have both ACS and PE for the reason why. But the older the patients get, the more likely it is that they may have several things as a reason for the symptoms. For instance, if you have an elderly patient coming and falling, well, falls in elderly patients are usually multifactorial, right? It's usually because of, well, maybe there may be a trigger like an infection or something like that, but also they may have bad vision and so on. So there's different factors, and there you can use this less. So this is more like in the specific patient and a clean question. I'll now show you how we can even use this even more. So I said we always want to consider the time critical and likely diagnosis, right? But let's talk about the not time critical and likely diagnoses as well, because sometimes they are really important to us, not just for symptom management, but also for diagnostic purposes to rule out the time critical conditions. And I'll show you how. So we have our graph again here. If I have a really, really good test, like something with a high positive likelihood ratio, for a non-time critical condition, but which is likely, then I can rule it in, right? You may think I usually give the example of a BBBV, like for dizziness patients. If I find if I have a Dix-Hallpike that is definitely positive in the right way, where they geotropic nystagmus, right? That is torsional. Then I have the diagnosis. But so that means that goes up, and therefore this one must go down below a test threshold. So that's how we sometimes is really important to actually know these tests for the non-time critical conditions. We can rule these out by ruling this one in. What must be true though is that I cannot do it with musculoskeletal pain. Oh, I'm pressing on the chest of the patient, and oh, it hurts. Well, that's not a good enough test, unless like it's really just 1 point. It's a young patient and it hurts right there, and it's the same. You can reproduce the pain, then maybe. But in most patients, that's not a good test. That's not good enough. At least it may increase the risk a little bit, but that's more like, most patients are sore on the chest, especially elderly patients. they have different conditions. They both have musculoskeletal and something else. Another example would be your patient with upper GI upset that you give a gastric cocktail to, and then you use the gastric cocktail as a test, which is not something that we should do, because that's not a good. It doesn't have a good positive likelihood ratio. It has a low positive likelihood ratio. So it only, like, the patient's symptoms may be relieved. Oh well, doesn't matter, because that doesn't really do anything. It doesn't get us below the time critical conditions here. So it all depends on what kind of time critical conditions you have when you're doing these things, and what your thresholds are, right? Because you do need to take the ECG on those patients of a GI upset if you think if that's relevant, right? You shouldn't just rule out the non-dangerous things. Or you shouldn't just rule in the non-dangerous things with bad tests. Okay, so the criteria for actually being able to rule something in by and then ruling the time critical conditions out is it must be a sum of 100, right? It must be, they cannot have the sum of all differential diagnoses must be 100, meaning that they cannot have just they cannot have several reasons why they have one symptom. And that, especially in the elderly, that doesn't really work. Oftentimes, the complex elderly, sometimes we have to be careful with doing this. Then it has to be a really, really, really good test, right? It has to be a really high specific test with a high meaning that it has a high positive likelihood ratio. Like the Dix-Hallpike in the BPPV, and not like the pressing on the chest in a older patient reproducing their pain, and not like giving a gastric cocktail to someone who you think has gastritis. And you need to make sure that the condition that you're actually, like, if you take the gastritis case, ACS is quite high pretest probability, right? Because it's kind of chest pain, and it has a high pretest probability there. So even if that gastric cocktail was a really, really good test, then it may not have been a good enough test to make it get below the pretest probability. The post-test probability, or like the test threshold. So it kind of depends on what kind of conditions you have here. It depends on how good the test is, and depends on the entirety of the patient, like how likely it is that their symptoms are. There's just one cause of their symptoms. And oftentimes it is only one cause, but yeah, that's what you have to consider. And that leads us to making errors in emergency medicine, because making errors in emergency medicine is usually a failure. Like, this is Eric Driver, it's the failure to approximate the probability of time-sensitive conditions based on available point-of-care information. Means that we care less about the process, like, oh, it was a PE, it doesn't matter. I want to know at the time that we're testing, how likely is it that, like, from with the data points that I can gather right now, within reason, could I have made that diagnosis? And if I couldn't, then it's not really a failure, and then it's something else, right? So we care about the process, and I might illustrate it like this. So this is from Simon Carley, and he usually talks about, like, well, this is also the thing about patients present here, right, with some kind of symptoms early on in the disease process. We are much more likely to guess wrong. That's why we are probabilisticians, not diagnosticians. It's not totally clear, but tomorrow it may be clear. But when we do a lot of things here in the EM, and even if the primary care physician doesn't do anything, like, really early on, the ones that come after them may think, oh, we shouldn't have done that. We shouldn't have sicked when we should have sacked. Why did they treat the patient with antibiotics because of hypotension in the emergency department? Well, we did it because the data points that we had were that you have a patient coming in who's 99 years old. They have a temperature of 35.7, so a bit of hypothermia. They have a CRP of 30. You can't give any history. They are also hypotensive, and you don't know why. You cannot find a reason for their hypotensive, and they have a lactate of 4, and they may be immunosuppressed or something like that. It may turn out that that this was only dehydration, and they might have a viral condition and so on. But from the data that we had, it was unwise, and from an emergency medicine perspective, it was above a test threshold or a treatment threshold to actually treat as a sepsis with antibiotics, because the test was good. The test was not that good, but the treatment is not harmful, or not that harmful, and it's really detrimental to not treat. So that's what we call a retrospective scope, right? We don't care what it is, but we care with the data that we had, that we made the right decision. Because if you do cases prospectively and not retrospectively, I'll say that again because it's really important. If you do cases, when you do cases, do them prospectively, like as I just did. Here's the case, here's the patient, here's the data that I got. What would you do with this data? Do you want to admit them? Do you want to send them home? We don't know what the resolution is. Actually, you don't need the resolution sometimes, because you just need to know from this data what you want to do. Do you want to gather more data? That takes a bit of time. I sure want to do that. You can do that. Do you want to do a CT scan? Do you want to that's how we should think about it, because then if you do that with a lot of people in your morning rounds, or when you're sitting with your colleagues, then if you do that right and in a humble way, then you can see that all people will make different decisions, and you can then calibrate how should we do this. And you can see that there's a high variation in emergency medicine and in medicine in general on which data points do we think are important, which data points should we weigh the most. And the entire thing, and when you're doing cases like this, then someone has already picked out the puzzle pieces for you. And that's always a bit it's quite hard to pick out the puzzle pieces from from the 6 puzzles that has been mixed together. And you should be able to acknowledge that when you're being presented a case, then someone has already done that, picking out of the puzzle pieces that are important. And some puzzle pieces may be missing, or there may have been really hard to actually pick out those puzzle pieces, and then because of that effort they made an error as well. But just saying that there's something before actually when the case is presented, that is more like connecting the dots, and that's important too. But yeah, I think you get what I'm saying. Okay. I'll skip these, and then I'll move to the critically ill patient, because so far the concepts that we're talking about has been mainly about non-critically ill patients. You can use all of these things in critically ill patients as well, but they are mainly used in the non-critical patients. I guess I usually see it as an overlap, and I'll show you a illustration later on here. Because of the overlap, there's an overlap between what you call system 1 thinking and system 2 thinking. And what we just went through is more laborious system 2 thinking. This kind of it's hard. It's something that we have to force ourselves to do. And in the emergency bay or resus bay or the critically ill patient, then we don't have time to do that from the get-go. We have to do stuff, and then we can sometimes do a stop and think. But it doesn't mean that it's not necessary to think about probabilistics when I'm doing a resus case. But it's less so. It's other mechanics that are involved there. And I'll just quickly show you some of the things here in critically ill patients, some of the thinking of an emergency physician. So you know your ABCDs. This is not a walkthrough of ABCDs. This is more conceptual. Okay, so three concepts in the critically ill patient, or 3-ish concepts. Concept number 1. Okay, so the first concept is this. This is Patrick Croskery's version of Daniel Kahneman's System 1, System 2, or dual process theory from Thinking Fast and Slow, his book. But Patrick Croskery is an emergency physician and psychologist, and professor of emergency medicine in, I think it's Dalhousie University in Canada. He's written a lot of books, and some books that I've referenced in the beginning are really, really good. He had written some case books on this as well, so that I highly recommend. But he illustrated that the decision making theory, the prevailing decision making theory like this. So you have an illness presentation, and then you then you go through, like, either you know what it is or you don't. If you know what it is, then you reflexively, or even you know what it is or you think you know what it is, then you go through it like this. So I'll remove some of the clutter and then we'll go through it. So we have these puzzle pieces that we're picking together, and we're kind of seeing what is this, and is this really something for this patient or something that's unrelated, and either we think we know, like we do what we call premature closure. We may like, oh, I think low blood pressure, redness on the chest, and he just ate peanuts, must be something like this is the pattern of anaphylaxis, must be that. And it's very reasonable to think that. Or you may be a novice just out of med school, or maybe even in med school, and you don't recognize these data points. Then you'll go through a different process, system 2 process. And the system 2 process is what we just went through. Like, it's more like the laborers. Like, okay, so someone give me the differentials of someone with hypotension. Okay, that could be. So you could have someone with sepsis. You could have someone, so on. You make a list, and then you kind of weigh up what could it be, what could it not be, and you come to a conclusion and you treat it. You may come to the same conclusion as the experienced one, right? But not if it presents in a more nuanced way. Not always, anyway. So that's kind of how it works. Like, either you know it or you don't, and if you know it or you think you know it, then you go in system 1, and that's kind of a reflex. You don't really think here, you just do. And the important thing about system 1 and system 2 is that system 2, in an experienced emergency physician, or anyone experienced, should be the main system. It's the main system of all of us all the time in our lives. We are experts in our daily life, right? We don't think about how to brush our teeth, or we don't think about how to do all of these things. That's why it's when you have a stroke, then it kind of it's reset some of these things. That's makes it hard. Try to do everything with your left hand during a day, then you'll see that what all, or if you're right-handed, of course. But if you're right-handed, try to do everything with your left hand and see how much of it is pre-reflexive. You don't think about it, you just do it. The thing is, though, if, like, even the experts need to do a stop and think when you are in the resus bay or when you are with a patient that is not critically ill, because if you don't do that, then you'll miss things. And what you'll miss is sometimes you'll do what, like, when you miss things in this system, you will call it cognitive biases. Oftentimes, you may say that, you may not be able to pick out that, the hypotension and the rash and so on. It wasn't the anaphylaxis. It was toxic shock syndrome. Like, the patient had a infection. That was why they were red. They just happened to just have eaten peanuts, and they got hypotensive because of the sepsis that they have with the toxic shock syndrome. But you didn't take the temperature because you premature closed your diagnostic process too early on. That would be, even an expert could do that, and like, we all do these things. That's why system 2 is really good at being the police, right? To do a stop and think, and we need to do that when we're doing resus, especially when things are not going the right way, but also afterwards. But if you usually in resus, you do one thing and you treat them as you go, and then you kind of pick up the patterns and you treat that to buy time to stabilize the situation, so that you can think, what should we do now? The thing is, though, that the battery of system 2 is laborious, and the battery sometimes wears out. And it wears out with the more amount of decisions that you have to make, the more cognitively loaded you are, like you don't have any bandwidth, and a lot of other things, right? If you're sleepy, if you are in a bad mood, so on, and so there's a battery here, and this rational override, this kind of policing of the system 1, we need both systems, but we need system 2 to be kind of policing the system 1, to make sure that sometimes we stop and think. So, but if we get distracted, if we don't have enough sleep, if we have less focus, if you're cognitively overloaded, if you don't have resources available, and so on, like this battery drains. So during your night shift, like in the end of the night shift, you don't have a system 2 left. You just do things drunkenly, and oftentimes it's good, but sometimes if it's a really critically ill patient, you should stop and think, especially if it's not going the right way. Oh, the blood pressure is tanking. Or going, even though we give them fluids and we give them adrenaline, the blood pressure is still going down. Are we missing something? Could it be something else, right? Should we give prednisone? You may not come or Solucotef for Addison's. Yeah, that could be it. But you don't think about that unless you activate system 2 from time to time and go through some of what you call mental models or mind maps, as we'll come through. You may have a bigger chance of having your system 2 hopping in sometimes if you develop what we could call good habits, such as forcing strategies. This is like, it could be a way of thinking like you can implement in your own head, kind of. So forcing strategies might be, so so this patient that with chest pain that we were talking about before, you could think this can only be PE. It can only be PE, and then you can stop and think and say, okay, so like from some futuristic kind of, like, now this is not PE. Someone tells you in the future this is not PE. What could then be? Because then you kind of stop. Okay, it's not PE. I think it's PE, but it's not PE. What could it then be? That gets your thought process going. Or it could be this. It could be this. You can also think about the graph that we just showed, the landscape of illness graph, where you have the different differential diagnoses. So if you think, oh, this can only be PE, well, it cannot only be PE. 100% and 0% are never on the map, right? It's you can be somewhere in between, but it's never only PE. So what could it be other than PE? So if you say PE, it can only be PE, then how much would you gauge that is? Like, is 40%? Is it 30%? And then once you've done that, then you kind of ask, okay, so you say it's 30% risk of PE. What are the, so that means 70% of the differential diagnosis are not PE. What are there any of those 70% that could be dangerous and time critical? And if so, are they above a test threshold? That's also a way of doing this. And it could also be, what if, like when you're doing cases with your pals, then you can say, like, okay, so this patient comes in and it has chest pain. If you want to become good at something, then you have to think of the what ifs. So what if it's a pregnant patient instead? What if they said it was aching, and what if they said it was sudden chest pain and not slow onset, and so on. So that makes you think on in different areas and encourage you, both in practice but also in real life, right? To kind of force yourself to sometimes use this. And you shouldn't do that all the time. You should do it in strategic points during the diagnostic encounter with the patient, both in resus and outside of resus. Okay, but resus is much more a system 1 game because we don't have too much time to do this stop and think, and oftentimes it's more of a what Sarah Krager would call an iterative hypothesis testing process, or what Scott Weingart would call OODA looping, OODA looping. Much like what I talked about situational awareness. So you gather data, you have a hypothesis, and you treat that. And if it doesn't work, then you gather more data, or you kind of work your way to a different level of either you have enough data, or you look at the data. Sorry, either you have enough data or you don't have the right data. So either you gather the right data, or you kind of get looking at the data that you already have and either ask someone, can you look at this data? I cannot figure out the pattern. And then you revise your hypothesis and then you treat again. So I will, the hypotensive patient that came in with a rash, it was perfectly, like if they're crashing, perfectly sensible to give them anaphylaxis treatment. It's cheap, it's not dangerous, just give it. And then they may become better, but then you find out, oh, they also have fever and they also have CRP of 400, and it doesn't really fit with this, even though I did treat the condition, but sepsis is also treated with adrenaline, so maybe we should give antibiotics. So you don't have an entire, you don't do this Bayesian probabilistics where you set up all, oh, it could be this, which time critical conditions could it be, but you kind of see that, oh, the treatment is not totally working, you'll do something else, and then you do a stop and think even every once in a while where you do the probabilistics, and then you kind of stop and, okay, now I can think about, could it be this, could it be, and what you actually do create is what you call mind maps. And if you saw the last dual process theory graph or illustration, you'll see that the more you do system 2, the better your system 2 gets at a specific task, then it will become system 1. When I brush my children's teeth, when they try to do it, it's really laborious for them. They don't know exactly how to do it. They don't know how to feel the position of the brush in their mouth and so on. But once they've done it 100 times, then they'll become experts at it. But that doesn't mean that they don't go to the dentist and they don't develop toothache at some point. If the way I taught them is not perfect, then they have to be taught by experts to a manner of speed, to cover those holes, so that they can brush in a way that they will become even better. So we continuously develop our system 1 through our training in system 2, deliberate praxis, right? Okay. And this is just another way of showing that Resource 1 is mainly a system 1 non-analytical method game, system 1, and outside of the Resource Bay is more like a system 2. But we use both of them in both games, right? And the reason why it's more system 1 is because it's more time critical. We need to make decisions now. We cannot do this laborious thing. Okay. So once we see the patient, is usually this is the way Eric Driver usually talks about it. The first thing is gather data, 0. We see the patient, gather data. It's like Mr. Bean. We just have to gather data. Then you do, I don't see Star Trek, but a lot of people like this. So it's kind of this is Captain Kirk, who's more goes with the gut. You get your gestalt, you get your patterns, and you treat. And then after a while, then you stop and think. Exactly. So what is the puzzle pieces? What counts as a puzzle piece? Do I recognize these puzzle pieces? This is sense making, and then am I sure? Then I have to check my math, right? Yeah. The challenge is becoming a well-calibrated expert at system 1 and system 2, and not overusing your system 2, because we may fall into a problem with kind of trying to overuse system 2, especially in the beginning. And that's where deliberate practice and doing cases with your buddies and so on, how to become expert at this is a separate talk, but this is some of the things that you could do. Just to show that, when we're talking dual process theory, then there's all these biases, cognitive biases they're called, and there's this called the snowball effect. So if you step into one of these in the beginning, then you'll just get more and more and more and more biases actually. So it's important to keep an open head, open mind, just not so open that your brain falls out, right? So you have to make decisions in the beginning. You have to do things. You have to weigh data points. You have to connect dots, but you shouldn't connect them so strongly that you cannot say that, oh, here's another dot, here's another data point. This may actually not be anaphylaxis. It may be sepsis. So you need to, it's this kind of paradoxical or balancing act where you have to treat, but you shouldn't you shouldn't be too sure about everything. You should treat, which is most likely, but you should always keep an open mind. And if something goes south, you should be able to be cognitively flexible enough and humble enough so that, oh, I made a mistake, I missed this, I'll go that way. And that's why we in emergency medicine in Resus Bay talk about teamwork and more eyes on the patient and so on, and psychological safety, so that everyone else can come with those suggestions to you as well if they need to. Yeah, here's some more cognitive biases. And I won't go into, I have different videos on cognitive biases, but in general, you should think of cognitive biases like premature closure, and we talk about separate retreat, and you can also, there's lots of cognitive biases, and there's almost too many, right? So, but they're not only negative. System 1 is often set to have most of these, but we cannot work without system 1. So we think about these cognitive biases maybe as like there's always a counterbalance to them. So we have premature closure, you get the information and you say it's anaphylaxis. It can only be anaphylaxis. You treat it and you don't think about anything else. But the counter to that, you just heard my lecture. It could also be sepsis or toxic shock syndrome, or it could be this, or it could be this. But but the patient is dying ahead of you, like in front of you. Then you're doing another bias, the opposite bias, which is paralysis by analysis. Oh, but when you hear hoofbeats, then it's almost always the most likely one, right? Yes, it is, but you shouldn't, like the opposite to that is separate retreat. And it's kind of like all of these, you can go all the way down here, like, errors of commission. You shouldn't do too much, like overdiagnosing, over treatment, over everything. But there's always error of omission. You didn't. We missed to actually treat with antibiotics because we didn't think of the hypothermic 90-year-old patient actually could be sepsis as well. And what I want, like my main take home is, like when you hear biases, they are important in their own way, both of them. And Catherine Montgomery has written about this paradoxal, like yin and yang condition that we have in emergency, like in medicine in general. In her how doctors think book, like we have these paradigm, like we have the heuristics that are, and we have opposite heuristics to those. And my conclusion is, it depends on context. It's a balance, and it's really context dependent. So premature like in the Resus Bay, it's really important to just get data, treat if the patient is sick, and optimally you've thought about it before, what you would do when you have gathered this kind of pattern of data. But if you have time, then it's probably sometimes better to stop and think and actually do that. In the Resus Bay, it's really bad to miss a thing. So if someone comes in looking really bad, then I'll do things instead of not doing things, because the life is on the line. But on the other hand, if they're not looking really sick, then I'm in more risk of just of actually overdiagnosing them and over treating them. So it depends on context, these things, right? And if you want to talk about like Scott Weingart talks about the New York way of doing emergency medicine is doing it with like a bias toward, like they want to be more towards the era of commission than era of omission. They want to do more, and especially like if you're in the Resus Bay, you want to do more instead of do less. And I get that, but outside of it, and in Sweden, then it's better to actually, like I would say, I'm more on the era of omission than commission. optimally we're in balance, right? We should be here, but that's like, so we shouldn't think of these things as something to avoid at all costs all the time, because they have a different like counteracting bias all the time. But we should um, like a, we should be aware of them. And Daniel Kahneman, who's made the dual process theory thing, and Thinking Fast and Slow, and who's Nobel Prize winner, he would say that, oh, you can tease out this bias and you can tease out this bias, and you can see how bad your system one process is. But Gary Klein, who is the counteract to Daniel Kahneman, Gary Klein, also a cognitive psychologist who's made the who's instead of studying as Daniel Kahneman did, he studied like Daniel Kahneman studied non-experts in who did tests like math problems and such, and then they found out, oh, they have premature closure, oh, they have separate retreat, oh, they have these things. But and I say, and he would say like, oh, we were so bad at like being experts. But Gary Klein studied patients in the real, like, or sort of people in the real world, like emergency physicians, like firefighters and so on, and he shows that, well, yes, there are these biases, and experts are not perfect in these biases. Like, we are prone to these biases, all of us, and so are experts. But experts, if you don't use system one, then you will fail at the experts level. Like, you will not be able to extinguish the fire. You will not be able to treat the patient in the really sick patient, because you're thinking too much. You're thinking too much about all of the biases. You're thinking too much about. So what we actually should do is develop habits, and design our like be able to become experts, like teach how to become experts, and then kind of as experts develop these habits of knowing like forcing strategies or checklists or so on. Yeah, it's another talk, but it's just saying that this is not easy. It's something that like there's still need for expertise in a long way, and actually we should be moving much more to education and getting getting people to become experts. But that's another talk. Okay, concept 2a. So when we're doing this, there's two parallel processes. There is the when we're doing seeing the patient in the resuscitate, there are two parallel processes. There's the before we know everything, treat as you go. You just gather your A, B, C, D, E's, or if there's low saturation, then you'll put oxygen on. If there's low blood pressure, then you'll give fluids. Yeah, and then along with this process, you'll gather data. And the data will become this kind of syndrome management that we talked about. Like, you'll gather the pattern. And once you have gathered the pattern, you need to treat the pattern, even though you're not sure, especially if it's a non-dangerous treatment. If the patient is looking bad and they need treatment, right? If you got time, then you can kind of think it out. But if you don't have time, then you don't have time. Then you have to treat. And the analogy here is the archer. The it's called, I can never remember this. It's a Buddhist telling. It's a Buddhist story of the archer and the poisoned arrow. I cannot remember the exact name, but so you have someone who is riding a horse, and he is getting hit by an arrow, and he will and others gather to help him, to see if they can help him with like getting the arrow out, but because they can see it's poisonous, this arrow. But he doesn't want the arrow removed before he knows who shot him. And that means that leads to his death, because they couldn't remove the poisonous arrow because they never found who shot him. And that's kind of the analogy here. So the arrow being that you should not. You don't have to be perfectly sure of your diagnosis. You don't have to know who shot, right, before actually removing the arrow, before treating. Because if you do that, then time will run out. You have to think on your feet. You have to create one kind of pattern, premature pattern, a hypothesis, and then you'll have to treat that. The problem becomes when the hypothesis that you gather is that if the treatment for it is paradoxical to some other hypothesis that you have. So it may be your patient in pregnancy who's going into cardiac arrest. So one hypothesis could be that the baby has to come out. That's 101 in pregnancy cardiac arrests. The baby has to come out. But it could also be PE. So do you thrombolize because that treatment would be problematic to your to some opening someone's stomach. They may bleed out. Or another example maybe easier would be someone with ACS or someone you think have ACS you may also think has AAS, like aortic syndrome or aortic dissection. Treatment for ACS is PCI, like blood thinners, right? And stents. And the treatment for aortic dissection is you don't want to give blood thinners to those. So now you're in a bind. Now you need more data, and that's why you go to the CT scan oftentimes there. So when you have a treatment that is easy and cheap, antibiotics and adrenaline, and you don't have time, then you give it. But if you have two problematic differential diagnosis where the one treatment will be detrimental to the other differential diagnosis, then you need to gather more data, and then you got to make a decision, right? Yeah, and this is just what I've shown you before. You can also use the analogy of the stars in the sky, right? You get a star sign from a data point, stridor, redness, and low BP. That must be anaphylaxis, right? A shock. It could be other things, but it probably anaphylaxis. But then you get another data point. Oh, it's also fever. Could also be, and it wasn't probably, maybe it wasn't like redness or like, then it could be sepsis as well. So you just cover that as well. In emergency medicine, we're not worried about getting it right, but we're worried about treating all the things that are above a test threshold or a treatment threshold, right? We need there's a lot of differential diagnosis, but we want to cover the things that are likely and most dangerous. And it may be it's usually not the most likely things. The most likely things are usually the benign things, but there's a maybe 2 in 10 chance or 3 in 10 chance that it might be this, and it's the 1 in 10. So there might be anaphylaxis. That might be a 4 in 10 chance, 40% chance for it being that. It might be a 10% chance of being sepsis. But if they're not responding to the anaphylaxis treatment, or it looks kind of like it's a atypical illness script presentation, then I want to treat with antibiotics as well, right? Because at 1 in 10 miss rate, 10%, that's too high, right? That's how we think. And then the day after, in the ward, they might say, why did we start antibiotics? It was obviously anaphylaxis. Well, with the data that we had at the time, it wasn't. And I would make the same decision again because of the process, the data points that I gathered and so on was valid. And then there might be a problem with my gauging of probability. Maybe it was 2% actually, because it wasn't really fever. It was hyperthermia, and there might be some studies and so on. Then I can gauge it, but the data that I gathered was true, and then I can calibrate the way I put together the dots, and you can do this more or less systematically. Scott Weingart has a podcast with Andrew Petro, where they talk about how you can systematize these things, where you can calibrate and become even better. Every time you've done a calculation like pretest probability, like in your head, then you should go back and see. Then you could adjust your it wasn't at all this. Then you can kind of adjust it. I don't think it's. I haven't gotten to where that is reasonable, and I don't think when I talk with my colleagues about this, I don't think this is reasonable at least not from what I know about this. But maybe in the future, maybe if we get more data, and more information about, like, we can be more precise in our diagnostics and more, but I don't think we're there yet. Yeah, and we talked about hindsight bias. It's the same, like retrospectoscope. Already talked about that, and we talked about, like, yeah. This is just to say, like, what we care about is the decision. We don't care too much about the outcome. Of course, we care about the outcome, but the decision, how we got there, the process is the important thing. This is what we should, for ourselves, say, like, oh, it's a good decision and a good outcome. That's good. It was a good decision, but it was a bad outcome. Well, I mean, we can reflect on, could we have done anything better? But in general, if the data points were the same, then we would have done the same thing. The problem is here, sometimes bad decisions are put up as a good one. Like, so if you have a bad decision, oh, I did the CT scan on this really low risk patient, and it turns out they did have a PE. Well, and they survived. Well, yeah, well, they had a PE and they survived, and you did the CT scan. Why did you do the CT scan? Well, I just had a hunch. Well, why did you have a hunch? Why, like, what's the pretest probability of this? You're allowed to have hunches. That's good, but, and especially if you're experts, that's good. Like, that's system one gestalt. But it is sometimes hard to explain your hunches. It can be done through something called shadow boxing, which Gary Klein has developed. But in general, you can't really explain your hunches. If you don't, if you made a bad decision, like, I wouldn't scan all asymptomatic patients just to find some kind of PE, like, which probably is, like, below a treatment threshold even. So that's not a good outcome. And sometimes, yeah, like, so a lot of the things that we do actually are bad decisions with good outcomes, because most patients are really good. It could also be a thunderclap headache. If you have a thunderclap headache patient and you send them home without any workup, well, 90% or maybe 70 to 90% of the patients with thunderclap headache, they don't have anything serious going on. They have just a benign kind of headache. Doesn't mean that they have a thunderclap specific primary headache. They may, for some reason, they have a benign headache. They don't die from anything. They don't have any problems with it. That doesn't mean that it was a good decision to send them home, even though they have a good outcome, right? And sometimes that thunderclap headache will go home and die, and then that's a bad outcome and a bad decision. We all make bad decisions which have bad outcomes in our careers. We should think about, it could have been me, because why was it? Was it and all of these, like, if you want to go through this, it's a totally different thing, but that's all about just culture and learn not blame culture, because there's a lot of things. It's not just the individual. I've talked about this in a lot of videos as well, so I won't go into details here, but in general, it's just, we shouldn't be too hard on the individual, and it's the bad apples theory. Like, oh, if we just get rid of that doctor or that doctor, but that's not. It's a system thing. And if you want to know more about this, check out, for instance, Sidney Decker, who's an expert in this field. Sidney Decker's YouTube channel about this, where he goes through his books for free. It's really, really good, and it's short and it's good. Or you can check out Rahul Patwari, Rahul, and then Patwari, where he goes through failure culture. Or Simon Carley's SMAC lecture on this, on second victim, or Simon Carley's blog on making good decisions. All of this is really good to get you around the fact that it's not the individual. It could just as well have been me in that situation, because of the complex system that we work in. We are supposed to be like hitting home runs all the time, even though that's impossible for any individual, even the best, right? And especially in a complex culture. So, yeah, Catherine Montgomery talks about this. Gross measures of patient outcomes are misleading because the correlation between the exercise of clinical judgments and the patient's subsequent health is poor. Poorly treated but healthy patients often make a good recovery. Well treated but seriously ill patients often die. All right. So why do we make mistakes? We do make mistakes, and we need to learn from them as well. but we shouldn't. But they're more complex than individual mistakes oftentimes. And how do we become better? Well, this is Patrick Croskery, and Patrick he usually says like 15% of diagnostic failure in emergency medicine. The failure rate is 15%, right? And you can look at that in a different way, saying like if you have someone like Jeffrey Braithwaite who says like, well, that means that in such a complex system, 85% of what we do is good. That's amazing, right? But why do we have diagnostic errors? Well, there's knowledge failure, or there's error-prone conditions like a really busy emergency department with crowding and noises and so on. Or there's a thinking failure, like either we gather our data suboptimally or we interpret our data suboptimally. This is about biases in system 1 and system 2. This is about knowing stuff and knowledge, like how to know likelihood ratios, which you know about now. This is about like politics oftentimes, and so we can do something about these two things mainly as individuals. The EPCs are kind of hard and something that we can do on a higher level and try to get a better work-life balance and so on, but that's harder. And Eric Driver would say that knowledge failure is the bigger one, and Patrick Croskery would say this is the bigger one. I think both of them are probably big, and I think both of them are important. Yeah, and we should always think like the emergency department is by Patrick Croskery called laboratory of error. It is a hard place to work, and decisions are hard. So don't throw anyone under the bus just because the primary care physician sends someone in who you may not think should have been sent in. Well, if it's a systematic error that they keep doing it, then something else. But if it's just one time, you don't know which patient they didn't send in this day. That's you looking through the spectroscope, and so on. And with the same coin, we should be humble. This balance: humble, but also know what we're doing, right? Yeah, and Croskery would say 75% of the diagnostic errors are because of thinking failures. Yeah. And as I said, Driver would say that it's probably more knowledge failures than we would think, especially in Scandinavia. Like in North America, they are drilled so much on the things, and it's so systematized, a lot of the teaching. So it's kind of it may be true, more true in Scandinavia, that knowledge failure is a bigger problem. That you don't know that if someone comes in who looks septic, and you don't know that if they have thrombocytopenic, you should do a D-dimer and a fibrinogen to see that they don't have DIC. Or if you have someone who has a pancytopenia and you don't do a D-dimer and fibrinogen, then you might miss an APL, acute promyelocytic leukemia. Or it's so there's definitely something about the knowledge failure that we don't know, right? That's why we need to kind of be systematic about it at home when you're reading this lecture or hearing this lecture, and preparing like in general for the life as a physician. And if you want to work in the emergency department, we need to kind of have a plan for these things so that we know what to do when these things arrive. Okay, concept 2b. So we have this thing about what you call the Weingart LLS score. So this patient looks like LSS stands for looks like shit. So sometimes we don't know what's wrong with the patient, but we kind of need to treat them anyway, right? This patient has a LLS score of 0. This patient has a LLS score of 1. Why do they have that? Well, we can talk about a lot about how do we gather the data and how do we see what others don't. How does an expert see that this patient is sweating and they're having a high pulse even before the vital signs comes in on the screen? You can see this patient is in a bad way, and this one not so much. But that's not what we're going to talk about now. If you want to check that out, check out my other videos on this topic. I just wanted to show you that oftentimes we gauge kind of, is this a sick patient or not, and that's what I become an expert at during my career as an emergency physician. You can check these links out if you want to know more about that. Okay, so we can kind of have in the resource bay patients that are look bad, but I know what it is. Okay, I know what to do. Then it's just about that I know my non-technical skills. I know what to do, but I can kind of get the things done. If I can get the things done, make it happen, then it's good. Then I've already prepared for it, and I can do it. If I don't know what it is, then this is a problem. This is when I want to get help. They look bad. I don't know what it is. Get help. All right. Okay. Concept number 3, mind maps. So if you have someone who has a low blood pressure, then to begin with, you have a novice mind map. That's like, low, and your mind maps are made up of physiology and experience and maybe some evidence as well. And so you have low blood pressure. The patient has low blood pressure. Okay, give fluids. That's a basic mindset. That's okay. Then after a while, then you may develop a more a mind map that is a bit more nuanced, where you may see, okay, what kind of differentials could it be to this? Are they is it dehydration? Is it vasodilation? Is it cardiogenic shock? Is it obstructive shock? Is it dissociative shock with anemia? And after a while, you can develop an even better expert mindset. Like so our mind maps is kind of, this is for me still like system 2, as you can hear, and this is definitely still for me system 2. But after a while, it becomes system 1. When if I only worked in the resource bay, then this would become system 1 for me after a while, and I would have this reflex kind of way of saying, okay, I know that these are hypovolemic because I can see that they're dry. I've checked their focus, and I can see they're dry, and then I'll just fill them up, and then I'll see if it helps, and so on. I'll skip this time. You can check out this amazing framework for shock in this by Sarah Krager in this homepage. And we just talked about these. This is just a mind map of a C problem. And this is an advanced mind map of a C problem. And this is an AB problem, low sats or give oxygen. After a while, you might think about it, what you call dyspnea pyramid, where you have all the differential diagnoses in there. Another, being a bit more advanced, you may look at the lungs and see, oh, is it dry lungs, or like you get a more syndromatic kind of mindset and mind map. And then after a while, you can get more advanced. I have just posted a video on this called Dyspnea for internal medicine. You can check out the entire lecture there. So the take homes about these concepts in critical ill patients, like system 1, is more a system 1 game than a system 2 game. Both are needed, especially system 2 to like calibrate and stop and think if it's going wrong. You need to treat before you have the diagnosis. That's we treat what you call syndromes instead of diagnoses, because syndromes is made of data points, but we're too early in the disease process to actually be totally sure. But we need to treat because the patient is critically ill. And if the patient is LLS1, buy time and call for help, especially if you don't know what it is. But even if you know what it is, sometimes you cannot get all the things done in time that you want, in the time span that you need. So you need more hands on deck. Okay, so how? Like the last bit of this lecture is, how do we do this? So how do we like actually get things done? And this is more about performance under pressure. And in general, check out Dan Dworkis' book on this. Check out Mike Lorian and Scott Weingart's podcasts on this topic. In general, you have what you call Jerks-Dodson curve, where you have a high performance when you're aroused, Goldilocks aroused. If you're too aroused and you get into the red, then you'll be too stressed and you'll pee your pants at a point. But oftentimes you'll get tunnel vision and you'll freeze. You don't know what to do. And if you're unaroused, then you're not performing strong either. If you're bored. Oftentimes in resus, you'll be somewhere around here, especially if the patient comes in now, like with no wait, like no time to check out what to do. What you have to do then is left shift your curve, and you can left shift your curve in different ways so that you come into the arousal, like this area here. And in general, what you can do now, like if you haven't prepared at all, you can breathe, like, and then there's different breathing strategies, but in general, if you want to be more aroused, like if you're here, you're going to go up here, then you should do more hyperventilation, like a bit hyperventilation kind of breathing. I'm no expert in this, but Rob Orman and Scott Weingart talks a lot about this, so you can check out their breathing lectures. But in general, usually you want to go from here to there. So what you can do is go from here to there by breathing in 4 seconds and then exhaling through your mouth to like the double amount of time that you had your in breath. So through your nose 4 seconds, and then through your mouth for 8 seconds. And then to do that maybe 3 or 4 times. Then you can talk with yourself. And talking with yourself is mainly to not getting this kind of negative thinking. So you need to think and talk about like, oh, I can do this. I've done this before. I've trained for this. I've been in this situation before. Maybe it's a long time ago, but I can do this. Or I've been to situations that are worse than this, so on. C, you can visualize, and we'll go back to that, and focus. That's like you want to have some kind of keystone or something of mental, like you can. Mike Loria and Weingart talks about if you every time he does a procedure, he says just before doing it, he says smooth, because he likes this thing called smooth is like slow is smooth, smooth is fast. So he says smooth every time he does something, and that gets his mindset into a focus, right? And you can train yourself every time you do a good thing, that you can use one word that you always. That's kind of conditioning. So smooth or good or something for yourself. You can read all about it in the paper in the Mike Loria paper, BTSF paper, and some of the references that I've shown. This is not a deep dive in the performance under pressure, just a taste of it, right? Visualization is so important, and probably the most important, because before getting into these scenarios, we need to visualize where all the stuff that we need to go and get. What if this happens? What if this happens? Then like we need to prepare for the what ifs. And if you want a detailed explanation, go to Weingart's as well about this. Go to Dan Dworkis's book. I'll list it in the references now. Or go to somewhere like Chris Hadfield's. He has this book called Astronaut Guide to the Life on Earth, or his lectures or podcasts. They're really good at like this, why it's so important to visualize stuff ahead of time. Or Martin Bromley on Mastering Intensive Care. He has this called Armchair Flying. They're really like, you need to sit down and go through the steps of what to do in different scenarios, especially if you're working out while you're doing it. You have a pulse that is up while you're visualizing. That is even better, because then you are stress inoculating yourself. But the best like visualization video, if you want to go into this stuff, I'll show you on the next slide. Okay. And in your downtime, you can make these mind maps. You can you can get this kind of what to do if in this situation. So you have what to do in at least the first couple of seconds in different scenarios. Okay, so another way of just showing you this, I think, is one of the last slides. So you have before the patient comes in, and then during the resus, right? So long before you'll do visualizing tasks, you'll keep up your knowledge. So to like you drill the knowledge that you need to know. You'll learn concepts and making the second nature. If this happens, then that should happen, right? If low blood pressure, then you'll do this. If the patient is pregnant and comes in with cardiac arrest, then you'll prepare this, and this. This is all about like logistics, not like, as I said, amateurs talk strategy and experts talk logistics, right? This is all about logistics, how to do that, how to make it happen. And then just before the patient comes in, you'll do a 0-point survey. If you want to know what a 0-point survey is, then I'll show you right away. This is the lecture about the visualization. It's seriously important. Check that out. You can also check out the thing about deliberate praxis and expertise by Scott Weingart. There's this great one by Rob Orman on zero warning, Scott Weingart's on framework for no notice critical patients. This is a 0-point survey done by Cliff Reed and others about how to prepare your team before going into battle. And I've made several videos on this, so check out my other videos if you want to. Then during the encounter, then you'll have this like system 1 more than system 2 iterative concept. You can check out Sarah Krager if you want to know about this concept a bit more. And then after a while, you've gathered enough data to actually say, okay, this is probably anaphylaxis, then you'll treat it. And how do you then treat it? Well, this is the bold-face manual, as Scott Weingart calls it, or resuscitation crisis manual. And once you've you gather the data, you kind of know what kind of syndrome it is, then you can look up these syndromes here and then treat them. And if it's not that syndrome, like again, syndromes, just like illness scripts, can be dealt into much more granular. Like it's not just low blood pressure. It's low blood pressure with wet lungs. Okay, that's probably a cardiogenic shock. It's low blood pressure with cold hands and bleeding, and it's probably a traumatic shock. So you can, it's not a, like the way I'm explaining is simplified, but you can, like, at some point you are at a point where you can kind of look up in the guideline and treat through the guideline, and then you just have to make sure that, oh, I'm not anchoring on it. If it's going the wrong way, I have to make sure that it's not something else. Okay. Yeah, just to show you this emergency action drill. Here's the link to it. So if you have here's a lot of these sub syndromes, like what to do right away before everything. Like if you don't have any time at all, then what should you do as a reflex? And you can test these on yourself. Oh, drop off. Drop off gunshot wound to the chest. Get IVs, O2, manual blood pressures, and then I don't actually know what CAB is, and so on. Right, so you can test these on yourself. Okay. So that's it. There is a case in the end of this lecture. I will skip this time, and then you can just go to the last time I did this lecture, and then skip to the end where I go through the case. And it's the same case I go through in a recent lecture on chest pain for internal medicine. So you can just check that out as well. It's the same thing. So just to anchor it. So thank you so much for keeping up with us for almost 3 hours now. This is probably one of the most important concepts, or some of the most important concepts in emergency medicine that I've given to you. It's not the most important lecture because I know these lectures are long, and it's much better when I'm in person to talk with you about these things. But this is at least the next best thing, I think, and I hope you look through the references that we just showed you, and don't despair if you don't understand all of this. To begin with, I'm not the best of explanators. I'm not the best, especially not in English, and not in 3 hours. It's not the best explanations of these things, but I hope you take home some of the concepts, and if you can use them in the clinic and begin to think about some of the things, just one of the things, with your next case, then you can increase your knowledge in these things, and then you can become better and become more second nature to you. Okay, so thank you so much again, and bye.